afternoon po to all of our attendees today. I'm Dr. Jello Apostol from ThinkWell Philippines, Technical Advisor for the private sector. And I will be speaking po, no, as brief to everyone. This is a relaxed, very collegial event. It's really a conversation. The second of our conversations with both the private sector and the public sector, talking about issues and upcoming reforms under the Universal Healthcare Law. Before we proceed po, I'd like to please invite everyone to focus on the QR code in front. We do encourage that that you scan it with your phone so that you can register online this event. So we'll give you a few minutes. Right. So this is part po of our efforts to minimize opportunities for potential transmission. We do know that, in fact, to be completely honest, this is our first in-person event that we have hosted as ThinkWell Philippines ever since the pandemic started. And we wanted to make sure that we keep it as safe as possible for everyone. Okay? Yes. So we will have some of our okay. Okay. So I guess we can move on. Thank you very much for registering for this online for this event. So as mentioned, this is actually the second of our conversations with the private sector as hosted by ThinkWell Philippines Incorporated. And really talking about how the private sector can be better engaged in facilitating and implementing universal healthcare reforms. Our specific topic for today is really about engaging private providers in healthcare provider networks. Just as a bit of a background, our first conversations with the private sector was really about, the general features of the UHC law and potential opportunities as well as challenges for the private sector when it comes to being part of this reform. But for now, now that we have more details, we've had policies released by the Department of Health over the past 2 years, and we are gaining more and more awareness and understanding of what the different components of the law are. We've decided to take these future conversations, the succeeding conversations with the private sector, to discuss further these different aspects of the law and how the private sector can interface and come in. So for this second round of our conversations, it's really about private providers being engaged in healthcare provider networks. And we've aptly named this forum Back on Track, Full Speed Ahead, bringing to bear the initial theme of when we had launched the Universal Healthcare Law, which is really coming at full speed ahead when it comes to achieving health systems outcomes. But also back on track, we do understand and we do recognize that the past 2 years of having undergone the COVID-19 pandemic and still going through the COVID-19 pandemic has definitely set aside and sidelined some of our efforts when it comes to implementing UHC. But hopefully, we are hoping at ThinkWell Philippines that this, among many other conversations, not just by us, but also by different groups in the public and private sectors, can hopefully get us all back on track in achieving UHC goals. So next slide, please. Um, so to open our forum, our conversation this afternoon, we have invited Assistant Secretary Kenneth Ronquillo, who is joining us online. So good afternoon, ASEC Ronquillo. Thank you very much, sir, for agreeing to open and grace this event, this conversation on the private sector's involvement in HCPNs. Good afternoon, sir. ASEC Ken is joining us live.
Thank you very much, Dr. Jello. Good afternoon, everyone. My gratitude to ThinkWell Philippines and Momentum Private Healthcare Delivery for bringing together today different stakeholders from the national and local governments, the private sector, development partners, the academe, civil society, and non-government organizations. It has been more than 2 years since the UHC Act and its implementing rules and regulations were signed. Before we delve into details of implementation, let us remind ourselves of the purpose and intent of the Universal Healthcare Act. UHC aims to reorient health system resources and utilization towards high quality, equitable, comprehensive primary health care so that all people have reasonable geographic and financial access to services that address the greatest causes of disease burden within financial limits and in a way that does not lead to financial hardships. Primary health care is a whole of society approach to maximize the level and distribution of health and well-being by acting simultaneously on three components: primary care and essential public health functions as the core of integrated health services, the multi-sectoral policy and action, and third, empowering people and communities. To achieve and sustain and ensure access to quality primary healthcare services for all consumers, our health system needs to engage, optimize, and mobilize both the public and private sectors to provide primary healthcare services. This involves a deliberate, systematic collaboration of the government and the private health sector according to national health priorities beyond individual interventions and programs. It is imperative that the private sector takes part in the formation of local health systems as envisioned in the law, more so as strategic partners in providing our patients a choice of where they can access healthcare services, beginning at the primary care level. The private sector highly heterogeneous and specific policy approaches are needed to engage and manage it. The choice and implementation of these approaches require an understanding of the many different private sector across or actors that operate in primary care and their attributes. The private sector also provide a mix of healthcare goods and services, whether individual health services in the beginning or population health services later on. This may include direct provision of health services, medicines and medical products, financial products, training for health workforce, information technology, infrastructure, and support services like health facility management. As of yet, operational guidelines are currently being drafted at the national level to direct the private healthcare provider network formation. The operational guideline hopes to improve access to products and services with a public health benefit, improve technical quality of care, and manage, if not control, excessive treatment costs and exploitation of services. At the local level, we encourage the stakeholders here present to already map out the healthcare providers and facilities in time for public and private arrangements in motion once the guidelines are available. Let's make use of all domestic resources as part of our efforts to the continuous achievement of universal health care. I am happy to note that many of the attendees are our current and future UHC champions in their respective organizations. Surely, we will go home or log off, as the case may be, much better equipped to contribute to the UHC vision than when we first arrived this afternoon. Magandang hapon po sa ating lahat at mabuhay tayong lahat. Over to you, Doc Jello.
Thank you very much, Sir Ken. Of course, on behalf of people, we thank you, sir, for making time to grace this event and opening it, and acknowledging not only the importance of HCPNs as a key strategy for achieving health system goals, but also of the role of the private sector as a strategic partner in achieving those health system goals. So, sir, ingat po kayo. I know you have a very busy day ahead. And we do know, and you have expressed your intention to still join and listen through what will come out of the conversations that we will have this afternoon. So thank you very much, sir. And hopefully this conversation, this forum delivers based on what you've shared to us. So thank you very much po, Asek Ronquillo. So as mentioned, and also as a rejoinder to what Asek Ronquillo has shared to us. So Dr. Ronquillo really allowed us to revisit the original intent and purpose of the Universal Healthcare Law. And the law in itself talks about engaging the private sector when it comes to achieving the goals that it has set out to do. But also, he recognized that we are still in the developmental stages when it comes to developing the guidelines, the implementing mechanisms, as to how exactly can the private sector be engaged in UHC reforms in general and in healthcare provider networks, or HCPNs in particular. And that really served as the key stimulus or the main reason or premise as to why we have decided to host this conversation. We are at a very opportune time. This curated, this intimate group of people from both the public and the private sector, and even the academic policymakers, implementers, to really come together, share experiences, share updates, and most importantly, to share ideas as to how we can move forward and think through these implementing mechanisms together. So really, the main objective of this conversation is really, on the one hand, it's an informational forum. We have invited our valuable partners and bossings from the Department of Health and PhilHealth to give us some policy updates on what has been released thus far in terms of policy and guidelines when it comes to establishing healthcare provider networks and contracting private providers. But more than being an informational forum, this is really a conversation that should allow all of us from various sectors to share our experiences. Some of us are development partners working with UHC implementation sites, working with different health providers, both in the public and private sector. And this is also an opportunity for us to bring to bear those experiences and maybe find something that can actually be adopted in terms of policy or programming. And hopefully, in the next 4 hours, we are hoping to maximize this time to explore opportunities, concrete opportunities, and ways forward as to how we can exactly and effectively engage the private sector in UHC reforms and these HCPNs. So these are our key objectives for this afternoon. And we'll go through 3 sessions. These 3 sessions have been so determined so that we can cover as many different aspects of private sector engagement in HCPNs as possible. So the first session is really about policy updates, as well as early experiences of some implementers when it comes to engaging the private sector in HCPNs. So we'd like to liken it to scoping the road. What is the road that we have traveled thus far, and what does the road ahead look like? The second session is about really drilling down and discussing some policy and programmatic or interventional options to contract private providers into these HCPNs. And we do see this whole idea of contracting and contracting mechanisms as the vehicle, as some sort of vehicle, as how we can engage the private sector with clarity and effectiveness. So if the first session was really about scoping the road, looking back at the journey that we've had so far and what's ahead of us, the second session is really about checking the car. Do we have the does the car work? Does it have, do all its parts, are they in good shape? Do we have all the working parts to make sure that these HCPNs and engaging the private sector in these HCPNs will work? And then lastly, we also talk about, realize that beyond guidelines and beyond creating effective contracts, it's also making sure that our partners, our counterparts in the private sector are also willing and find the value proposition of being part of these HCPNs and taking an active role in UHC reform. So section 3 is really about the driver, understanding the driver in this case. Are they ready and willing to work with the public sector, not only in HCPNs, but even when it comes to participating in UHC reforms. So these are the 3 sessions that we have set out to, or the 3 clusters of topics that we were hoping we can discuss in today's afternoon's discussion. So before we proceed, we'd like to, of course, acknowledge each and every one of you po for making yourselves available for this in-person forum. We understand that some of you were initially hesitant, given that for the longest time we have been so accustomed to doing everything online. Of course, the real safety risks of doing events such as this. So we have tried as best as we can to make sure that this forum is as safe as possible for you. And of course, we'd really just like to acknowledge you being here and your willingness to contribute to these conversations on engaging the private sector in HCPNs and UHC reform. So we have, of course, our partners from the Department of Health and from PhilHealth, Dr. Lester Tan from DHSD, Dr. Mamaril from DPCB, ma'am. HPDPB, I apologize, ma'am. And we have also our program managers and point persons from DPCB. Thank you very much, ma'am, for joining us. Of course, we have Dr. Ish Vargas from PhilHealth. Sir, thank you very much. We also have our partners from the civil society. We have from USAID, Dr. Joseph Lachica. We have from Likhaan, Ma'am Janice Melgar. From the Integrated Midwives Association of the Philippines, Ms. Patricia Gomez. And we have representatives from academe development partners such as us. In ThinkWell, we have Dr. Rafi Marfori from the University of the Philippines, Philippine General Hospital. So thank you. Maraming salamat po. No, thank you very much for joining us in this conversation. And at this point, I would like now to turn you over to our Senior Technical Advisor, Dr. Maria Eufemia Yap, whom we have also asked to co-facilitate and moderate this afternoon's conversation. Dr. Marife.
Maraming salamat. Magandang hapon. I'm Dr. Marife Yap. I'm Senior Technical Advisor for ThinkWell here in the Philippines. In addition to those who are here at the Seda Hotel, I'd also like to acknowledge all of our participants who are online. I saw some names earlier when Asek Ronquillo was speaking. I know that some of our friends from Ayala Healthcare are in, as well as from Likhaan and other organizations. So please, you are all very welcome. And this is our first time to do this hybrid. So I see that Dr. Banzon is already in. So we'd really also like to encourage robust participation through your messages or questions maybe later in the chat box. So, okay, my task is really just to set the tone, no, before we begin with our 3 sessions. And as we have tried to say from since the beginning, this is a conversation. Of course, we know we're here in a hotel function room. It's a little bit formal, but what we'd really like to do is to get ourselves to talk to each other, or maybe to get private sector and public sector to really talk. It's significant that we have called this afternoon as back on track, full speed ahead. Just before the pandemic hit us, we had already started conversing with the public sector, private sector, I mean, to find out how they can really participate in the healthcare provider network. Unfortunately, na-discarril tayo because of the pandemic still ongoing up to now. But I think with cases more controlled, we have the opportunity to really get ourselves back. But despite all of that, we know for a fact that our colleagues and partners from public sector, particularly DOH and PhilHealth, have not stopped working. Despite trying to manage all the challenges of COVID-19, they have continued pursuing how UHC will be implemented. And that is what we will really hear in the first session. Where are they? What has been done thus far? But because the challenge is very huge, there are many snippets only of the story. And what we want to try to do now is, let's get this car to move faster, or in the imagery of UHC, it is the train, to get this train to move faster. So as we do that, we will listen to inputs, but we will also listen to each and every one with your questions. So as I said, since we took the time, either online or here, to come, let's be here and let's listen and let's hear what each other has to say. As you notice, Dr. Jello was saying, nakaupo lang ha, nakaupo lang. It's as if to say, parang, let's really make this kwentuhan para we have more chances to really put out. I said, we might end up at the end of this forum with more questions than answers. Sige lang. I think Dr. Lester, Dr. Pargas, they would like to know the questions because they have many things to attend to. And so we'd like to give everyone a chance to be able to say something. And I think you noticed that somebody handed blue cards. We're giving you these pieces. Write down your questions. We cannot guarantee that we will be able to call them out here because our time is limited. But we'd like to get them so we can document and we can share these documents to our partners. Of course, the others are just our usual, no? Listening with empathy and an open mind. Let's be honest. If we have real difficulty and challenges about how we get to participate as private sector to the UHC and HCP, say so and put out what are the seeming problems. But we want to do this because we want to move forward. We want to do this so that we can see how we will really be able to move and act on all of these. In the earlier, before we formally began, in the small conversations, we were saying, well, maybe somewhere down the line, the aspirations that we want may happen, but we have to get this to start. And I think that's what this forum is all about. So hopefully with this requests and also context for this afternoon, we can then move on, since our time is very limited, to move on to our first session. And our first session, as you already know, is what's going on right now? What's the road looking like? And for that, we have our 3 speakers. First, Dr. Lester Tan of the Bureau of Local Health Systems Development will give his updates. Then this will be followed by Dr. Lena Lagon Albior, who is our colleague for service delivery networks based in Region 6 for our partner provinces, Antique and Guimaras, our experience. And then we'll have Dr. Rafi Marfori of the UPPGH to also share his experiences on private sector engagement for achieving public health outcomes. So without further ado, we'll pass the ball on to Dr. Lester Tan. Dr. Tan.
Thank you, Dr. Marife. And I would like also to thank ThinkWell for organizing this stakeholders forum so that we will be able to also hear the suggestions of our different stakeholders and partners. Now, for today, I will be providing you some updates on some of the policies that we have conducted, as well as one study that we have conducted at the DOH with regards to healthcare provider networks and province-wide and city-wide health systems as mandated under the UHC law. Next slide, please. Okay, so I have divided my presentation into three. So first would be about healthcare provider networks and the integration of local health systems into province-wide and city-wide health systems. The second would be on our study on the assessment of selected networks of private healthcare providers. And the third would be our ongoing initial initiative on the policy framework for private sector engagement in province-wide and city-wide health systems. So the legal basis for the HCPNs and integration of local health systems are the following. So we have the Chapter 4 of the UHC law. So just a review for all of us. So Chapter 4 of the UHC law, Section 17. So it mentioned that the DOH shall endeavor to contract province-wide and city-wide health systems for the delivery of population-based health services. While Section 18 mentions that PhilHealth shall endeavor to contract public, private, or mixed healthcare provider networks for the delivery of individual-based health services. While Chapter 5 of the law mentions that the DOH, DILG, PhilHealth, and the LGUs shall endeavor to integrate health systems into province-wide and city-wide health systems. And thereafter, we also issued out and finalized the implementing rules and regulations of the law, as well as have issued also several policy guidelines in the form of administrative orders pertaining to these provisions. So guidelines on service delivery design of HCPNs, guidelines on integration of local health systems into province-wide and city-wide health systems, and the guidelines on implementation of the local health systems maturity level, and which I will be focusing my first discussion. So we have three types of healthcare provider networks, which is mainly based on ownership. So the publicly owned or public-led healthcare provider networks, or what we call also the province-wide and city-wide health systems, is on the left side. And they are mandated to deliver both population-based and individual-based health services. So this is the public network. And of course, they have the primary care provider network as the foundation, and then they also have secondary and tertiary care facilities that are linked to an apex hospital. So the law also mentioned that the PhilHealth shall be contracting apex hospitals, which are specialty hospitals, separately from these networks as a standalone health facility. And of course, given the public nature of these networks, they are bound by geographic or political boundaries. On the right side is the purely private healthcare provider networks. And of course, similarly, the ideal is that they have primary care provider network at the foundation. They also have secondary and tertiary care facilities, as well as also linked to an apex hospital or a specialty hospital. But given the nature of the private sector, they are not bound by geographic or political boundaries. So they are affected by market-based forces, and therefore they can encompass several geographic or political boundaries. They can have health facilities within their network across the country or within several regions or within several provinces. So that is the nature of the private sector. In the middle is the mixed healthcare provider networks, wherein both the public and the private are the co-owners of the health facilities within these networks. However, we don't have any existing models yet for both public and private ownership of facilities. No, what we have currently are only contractual arrangements between publicly owned facilities and privately owned facilities. No, therefore, that would be the focus of one of my next presentation, which is on the private sector engagement in province-wide and city-wide health systems. No. Okay, so as I've mentioned, so the public healthcare provider networks or the province-wide and city-wide health systems will be delivering both population-based and individual-based health services. And also as mandated by the local government code and also by the UHC law, they will be managed by the provincial and city health boards. Now, the UHC law also mentioned that only LGUs that committed to integrate shall be integrate their local health systems within the first 6 years. No, this is the 6-year transitory period. And of course, we had the initial 58 UHC integration sites. These are LGUs, provinces, HUCs, and ICCs that have committed to integrate their local health systems within the 6-year transitory period. And in that transitory provisions of the UHC law, it mentioned also that the nationwide implementation of this provision will depend on the recommendation of the independent study that will be commissioned by the Joint Congressional Oversight Committee on UHC, as well as the Secretary of Health, through an executive order that will be issued by the President of the Philippines. Okay, so as I've mentioned, in order to track the progress of integration of local health systems into province-wide and city-wide health systems, we have developed a monitoring tool which we call the Local Health Systems Maturity Levels, or LHSML. And this will be the general framework in the monitoring and evaluation of the progress of local health systems integration. So we have outlined here a pathway to progressively realize the reform on integration. Since the UHC law also mentioned that progressive realization of UHC and will not happen overnight, which is why this is a stepwise approach. So this will be used in complementation with the LGU Health Scorecard and other existing monitoring and evaluation systems like the FHSIS and others to enable us to track the progress and health outcomes at the local level. And we also envision that this to be one of the bases in formulating and updating the programs, projects, and activities at the local level in relation to local health systems integration, as well as serve as a reference to determine the level of assistance, incentives, and recognition and awards for LGUs that will support local health systems integration. So there are different components of the local health systems maturity level. We have grouped them into the 6 building blocks, based on the building blocks of the health systems of the WHO. We have also grouped them into different characteristics of the province-wide and city-wide health systems to achieve managerial and financial integration, as well as several key result areas, which are the minimum outputs that are expected to be delivered by the province or city-wide health systems. And there are 3 levels of progress. So preparatory level, or level 1, covers the KRAs that are relating to preparatory works, such as baseline assessment of the different health systems at the local level. Level 2, or organizational level, covers KRAs that are important for organization and management of the integrated local health systems. And also level 3, or functional level, will monitor the functionality of these integrated management support systems. So I will not be discussing more about this because might take a lot more time. Just to mention that there are 3 levels here: readiness of the province-wide and city-wide health systems, organized, and functional. So what we have done already is that we have already several assessment reports of the 58 UHC integration sites pertaining to the local health systems maturity levels. So we have the FY 2020 National Baseline Assessment Report, which we have issued last February 2021. We also did a 3rd quarter progress report just to check their progress, which we have issued November 12, 2021. And just recently, we have issued the 2021 National Annual Report, issued last February 21, 2020. Okay. So I would now be moving towards my next set of presentation, which is the assessment of selected networks of private healthcare providers. So my first part mainly focused on the purely public sector. But now, as part of our work at the Bureau of Local Health Systems Development and as instructed by Yusek Mario Villaverde, we have tried to assess what are the characteristics or the profile of the existing networks of purely private healthcare providers. So we have jumped onto the other fence already to assess the purely private. So the objectives of this in-house study, so the staff of the Bureau of Local Health Systems has conducted this study, is to provide an overview of the selected networks of private healthcare providers, and also to assess their management structure and systems, and also provide recommendations on the development and policies and guidelines for private sector networks. And the methodology is desk review, a self-administered questionnaire by the different networks, as well as series of online interviews with them. So the scope of the study are the 4 major networks of private healthcare providers: the Ayala Healthcare Company, the Metro Pacific Group of Hospitals, the Mount Grace Hospitals Incorporated, as well as the Medical City Group of Hospitals. So these are just some snapshot of the company profiles of the different networks. So I will not be explaining in detail, but for AC Health, they have 3 arms. They're a pharma company composed of the Generica, IE Medica, and MedEthics. They also have Clinic in Hospital Corporation, composed of the Healthway, which are their primary care networks. They also have ongoing Ayala Cancer Hospital, as well as the group of Qualimed hospitals. So they have this group of Qualimed hospitals. And also the 3rd arm is the Digital Health Corporation, which handles their digital health portfolio, the Health Now application, the AID application, as well as some diagnostics procedures. On the Metro Pacific Hospital Holdings Incorporated, this is composed mainly of secondary and tertiary hospitals, but I think they also have a primary care provider. But in general, most of their the facilities in their networks are level 2 and level 3 hospitals, and they are scattered all throughout the country. The 3rd would be the Professional Services Incorporated, which is more commonly known as the Medical City Group. So they have the 2 arms: the Procer Health Services, which handles the TMC clinics, which you can see in the different malls and different parts of the country. And they also have the PSI Healthcare Development Services Corporation, which handles the different TMC hospitals, as well as the TMC Iloilo. So they have, of course, I forgot to mention at the top, the Professional Services Incorporated also handles directly the Medical City Hospital in Ortigas. While the PSI Healthcare Development Services Corporation handles the different TMC hospitals in other parts of the country. So they have, as I've mentioned, they have primary care providers, and they also have level 2 and level 3 hospitals. Okay. For the Mount Grace Hospitals Incorporated, they have 18 partner hospitals, mostly, again, level 2 and level 3 hospitals, as you can see here. And they do not have primary care level facilities. And this is under the United Laboratories Group or Unilab Group. Okay. So I will now be presenting the profile of the results of the assessment for these 4 networks as a group already. Now, so in terms of human resource management, the hiring and recruitment of these networks mostly are on a per individual facility. And sometimes they also have, one network also has centralized hiring, but the processing of the HR is already on an individual facility level. They allow network transfers of their human resources to the different facilities, but of course, it will also still follow the individual facility processing. With regards to funding for capacity building and mentoring, sometimes the hospital funds the capacity building, or the network funds the capacity building, or most often there's a cost sharing between the hospital and the personnel. With regards to separation and termination and retirement of their human resources, it's mostly on a per individual hospital company policy, following the Department of Labor and Employment guidelines. In terms of financial management, we have found that there is no centralized financial management in all of these 4 networks. They may have centralized monitoring of financial performance and consolidation of reports, but these are mainly for investment purposes tracking, but not really to monitor and really deep into the operations of this financial management. With regards to pooling of income at the network level, none of the 4 networks have pooling of funds for the whole network, and therefore the finances of each facility in the network stays within that network, because we know that they also have, each facility, each hospital will have their own shareholders and stockholders and board of directors. And of course, there's no standardized costing of services across the network, simply because, as I've mentioned, they are scattered in the different parts of the country, and therefore, sometimes the location of a facility and the population, catchment population that they serve will affect the costing of their services. With regards to, still on financial management, this is an interesting finding with regards to the sources of income of the facilities within their network. And they mentioned that their income comes from PhilHealth. 5% to 25% of their income comes from PhilHealth. 24 to 40% is from HMOs. 48 to 60% are from out of pocket, while 3% is from others. With regards to budget allocation, the 18 to 38% are from salaries, 20 to 59% for operation expenses, 8% to 20% for capital expenditures, depending on the presence or absence of existing equipment already. In terms of procurement and supply chain management, the procurement of equipment, drugs, commodities are on a per facility level and not on a network level through the procurement management department of each hospital within the network. Sometimes they do centrally negotiated procurement, but the purchasing and the delivery is decentralized. One network has a centralized unit that handles bulk procurement, but only for certain big items, such as MRI, and not for small items like drugs and commodities. And they mentioned that when they do this centralized bulk procurement for big items such as the MRI, they really are able to save a lot of money when they procure in bulk these big items. In terms of asset management, it's still on a per individual facility or hospital level. And one of the network is also offering biomedical equipment maintenance services to its partner hospitals. So as part of the services that are being provided by this investment company, they also offer other services to their partner hospitals, which is the Mount Grace group of hospitals. In terms of patient navigation and information system within the network, so there is no standardized referral system for the whole network. They mentioned that referrals of patients are mainly based on the doctor's assessment, also the patient's choice and availability of specialists in the facility. So they can really refer patients even outside their network. They are not bound to refer patients only within the network. And in terms of transport, they outsource this to third-party service providers. And their EMRs are mainly used for internal referral, triaging, medication, and monitoring and billing. And they also do telemedicine and use mobile applications. In terms of outsourcing, it's also a common practice among private providers. They do service contracts for laboratory and diagnostic services, either within the network, outside the network, and even to public or to private facilities. As I mentioned, they also do service contracts for ambulance services, waste management, etc. So in summary, in terms of the integrated management system, each facility in the network operates independently since they have their own juridical entities. They implement their own management systems, but of course, as I mentioned, the four networks have efforts to improve their efficiency whenever appropriate, such as centralized hiring, bulk procurement, centralized negotiation of prices, etc. And as I mentioned, all four networks are not yet really fully integrated, but they have efforts to improve their network efficiency. And private network is purely market driven, and based on the distribution, most of their facilities are concentrated in urban areas. They also are able to undergo contractual arrangements, but their issues on outsourcing services to public institutions is on the long turnaround time is a challenge for them. So in summary, establishment of one juridical entity among the network of facilities is a challenge in setting up a private HCPN, and therefore field health contracting of a network of purely private sector providers will be also a challenge. And as one of our interviewees mentioned, what is feasible and currently being practiced are contractual arrangements among the facilities. I would now go towards my third part of my presentation, which is an ongoing initiative. So this is our draft framework of policy on private sector engagement in the province-wide and city-wide health systems. And this is just an initial framework, and we would welcome your inputs on this as well. So we have at the bottom are the principles of engaging the private sector, and then the process of engaging them. So what is the rationale? What are the goals and objectives of engaging the private sector? Mapping of the existing private sector providers in the locality, and dialogue and joint agenda setting. And the different areas of engagement would be on policy and standards development, information and data exchange, financing, as well as the more common ones are the health service provision. And we can group this into different modalities, which are the non-contractual arrangements and the contractual arrangements. And under contractual arrangements are the build, operate, and transfer, or its variants, the joint venture agreements, and some other contractual arrangements that are not really BOT or joint venture agreement type of arrangements. So just to enumerate briefly some of the possibilities here on policies and standards development, inclusion of representatives from the private sector in advisory committees at the local level, in the technical or working groups, and of course at the local health board. Now, we know that the private sector is also part of the membership in the local health boards, at the municipal, city, and provincial health boards. It can also be engaged in the conduct of public hearings, consultation meetings, dialogues, position papers, project proposals, and policy proposals. In terms of information and data exchange, so there can be a presence of a system to integrate the different applications that would link the different systems within a network, a set of universal definition and standards, and a database that is accessible to all network members. And I know at the national level, PhilHealth and DOH are already working on this system. And also this information and data exchange between the public and the private sector should be in accordance with existing laws such as the Data Privacy Act, the Notifiable Disease Act, etc. Also on information and dissemination campaigns, capacity building of the private sector and knowledge transfer activities. In terms of capacity building, we have already expanded the capacity of the DOH Academy online resource at the national level, wherein the private sector can also access all of those online trainings at the DOH. And also another one is supporting the public sector or the province-wide and city-wide health systems management system. So the public sector can outsource to the private sector the management of this, particularly strategic financing and investment planning, HRH management, information system including EMRs, epidemiology and surveillance system, supply chain management, referral system, and the GMH system. So the private sector can also be engaged on these management systems. And also for health financing, so revenue raising to generate additional funds for the improvement of public health facilities, infrastructure, equipment, and services. And of course, service purchasing, wherein the local government can purchase health services from the private sector in behalf of their constituents to complement and augment the services that are not available in the public health facilities. And of course, lastly, on health service provision, so we know that in the private sector really provide individual-based health services, but they can also be tapped to provide population-based health services in the future, including public health programs. But I know there are already existing efforts wherein the private sector is tapped to provide population-based health services like vaccination, TB dots. We have the long-standing partnership with the private sector on public-private mixed dots in the past. So to ensure access to all levels of care, including specialized services, collaboration in the implementation of population-based health services, including public health programs, but of course, the public or the government should support the private sector and to provide them capacity building and the necessary commodities. And also to ensure continuous and integrated delivery of individual-based health services, such as through consignment and outsourcing, and resource sharing and mobilization, especially during public health emergencies or disasters. Now, for the different modalities in engaging the private sector, these are the contractual arrangements type. We have the PPP type contractual arrangements, which are guided by the national PPP policies, such as the Build, Operate, and Transfer Law, as well as joint venture agreements. And also, if arrangement does not demonstrate the characteristics of the elements under BOT law or joint venture agreement, this will fall under other contractual arrangements. But of course, the literature would provide other definitions for this. So sometimes you can see PPP contractual arrangements as PPIP, or Public-Private Investment Partnership, while the other contractual arrangements or the soft PPP are termed Public-Private Interactions. So these are some examples of this would be concessions, leases, or upper management contracts or service contracts, either with or without the use of LGU funds, donations, etc. And of course, these types of arrangements would be in accordance with the RA 9184, or the Government Procurement and Reform Act, and its IRR, the Civil Code, as well as the LGUP4 guidelines of DILG. Now, these guidelines of the DILG is a very comprehensive guidelines on engaging the private sector at the local level. So non-contractual arrangements, as I've mentioned earlier, is not limited to execution of formal contracts. No, this can be a simple referral of patients to the private sector, policy and standards development discussions, submission of reports, etc. And we are also trying to gather some sample templates for contractual arrangements between the public and private sector that would serve as an attachment to this draft policy that we are developing. So we will also welcome sample templates that our partners would also have for consideration. So that would be the end of my discussion for today. Thank you and good afternoon.
So good afternoon, everyone. I'm Dr. Lena Alvior from ThinkWell, and I'm honored to share with you all today the journey and learnings of and with our partner provinces, Antique and Guimaras, on the province-wide health system and their healthcare provider networks as UHC integration sites. So at the heart of the UHC law is the aspiration for every Filipino to be prevented from being sick. And if sick is managed well, with good health outcomes and protected from catastrophic health spending. With the devolution of 30 years, resulting to many autonomous local health systems, wherein municipality RHUs cover primary health care and provincial health offices focus on overseeing programs and hospitals, wherein DOH, augmenting for high-cost drivers, have also fostered learned dependency, and where PhilHealth capitation, though the most flexible, have been difficult to access, especially for primary care benefits. So the UHC laws, bold reform of province-wide and city-wide integration, seeks to reduce this fragmentation, optimize resources, have cost advantages towards more efficiency and clearer accountabilities. With managerial integration, this is the functionality and exercise of the Provincial Health Board, the PHB, as the steward of the local health system. We know the district health system, the interlocal health zone, the SDN before it became HCPN, and all of which point towards the referral integration from primary care to tertiary care, with the hope that Filipinos feel the basic quality care as nearest to them as possible. So the unique opportunity of the UHC law is really the financial integration. We all know that in the interlocal health zones, they just do counterparting, but they don't actually pull in money, so that for in the years that came by, it dissolved. No, it didn't really prosper. So the opportunity is really the financial integration, which has pooling of resources with a single planning and investment strategy. So that's the unique opportunity in the UHC law. And together with the provincial health teams, we believe and hope in the beauty of the UHC law, knowing that it aligns with their health visions. For Antique, it's as simple as healthy Antiqueños. For Guimaras, the Islanders, it's empowered and productive Guimarasnons, enjoying quality health as a way of life. So in the next slides, I hope you'll allow me to share with you our progress in these areas that we use not to support them. So This is the visual representation of the HCPN in Antique. It has 3 primary care provider network clusters with 5 to 7 RHUs per cluster. And the highest referral hospital within the province is a level 2 hospital, which is Angel Salazar. Also mapped out here are the private facilities present in the province. For Guimaras, this is an example of an HCPN that is a province-wide health system that is smaller than its HCPN because the highest level of care within the island is only at level 1, which is the provincial hospital. So Guimaras nuns have to ride ferry boats to Iloilo City to access higher level of care there. No? So that's the reality in Guimaras. As you can see here, the island province is composed of 1 primary care provider network with 5 RHUs, 2 infirmaries, and the provincial hospital, which is level 1. So they don't have a level 2, and they have to go to Iloilo City. So for the apex, same with Antique, they have to go to Iloilo City. And in early 2021, Guimaras was picked by the PhilHealth Regional Office 6 to pilot Consulta, and initial assessment showed that there were gaps in complement laboratories and pharmacies and doctors as required by Consulta. At the end of 2021, 3 of the government hospitals and 1 out of the 5 RHUs are Consulta accredited. Accreditation deterrents were mainly because of the COVID demands and the not so good experience of the RHUs with PCP. So they weren't really, hindi siya mabango for them, no? to try out Consulta again. DCG NPH, which is the level 1 hospital, the provincial hospital, was the only one able to proceed to try out benefit availment of clients. So 66 in total from November to December of 2021. The client distribution is from each of the municipalities in the province. None of the claims submitted have been paid yet, and the IT setup is the one that's being pointed out as problematic. Both provinces are currently finalizing their HCPN manuals with the aim of piloting their first iteration in the coming months, hopefully by May. And gatekeeping is still largely geopolitical in the context of progressive realization, which we always emphasize. The meat of the manual is establishing and clarifying the navigators per facility and functionality of the public health units in the hospitals, and the navigator tools, which are the Directory of Health Facilities and Services, their standard province-wide referral tool, client satisfaction survey, and an HCPN incident and feedback form. So critical as well is the MNE process. This one we really want to implement, to follow this in the implementation. So consolidation and analysis of referral data from providers. So right now, in our directory, we have all the public facilities, but we have opened it to all the private providers in the province. When they commit to being part of the network, then their names and their services will be included in the network. So that's how we try to enjoin them to come in. And then we have the HCPN Technical Management Committee, or its equivalent, composed of the PHO, PDOHO, public provider representatives, and private provider representatives. So in the different DOH diagrams, all of these are really the health systems, the development unit of the PHO, together with the primary care facility operations and the hospital operations coming together with a private sector representative. And all technical matters will be discussed here in terms of the network. And if there are decision-making for health interventions, health issues, or health investments, they will be raised to the Provincial Health Board. This will be our contribution to the technical integration. So the PHB, the Provincial Health Board of the province-wide health system, is critical. In the two provinces, the mayors have been included as representatives. However, irregular meetings have been made because of the pandemic. With the Management Support Unit, the MSU, which is the admin and finance secretariat of the PHB, this one is hired. They have 3 persons hired in Antique and 3 persons designated in Guimaras. They have an attorney on board, they have an accountant on board, and we are striving to have more regular meetings, better now with the lowering of the COVID cases, but election and its campaign process is definitely a challenge. No? So that's our main challenge now. For both provinces, the Special Health Fund account has been opened and with initial deposit borrowed by respective province finance teams from other sources. And from time to time, the finance team asks the health teams, when will the actual SHS funds come in? Because it's already there. It's open, but may time limit yung initial deposit. No? There is an opportunity also to integrate the LIPH of the next 3 years to the PHB as the single planning tool of the MSU, and also incorporate Mandana's health-related DTP into the conversation, into one strategic plan moving forward. These are horizontal system-wide efforts we have despite the pandemic. And in the next slides, I will share a bit about a vertical program, which is family planning, as a subset of the HCPN, which can greatly contribute to it. So in Antique and Guimaras, there continues to be unmet need for FP among Wira in the 2 provinces. So I am an Ilongga. I am also an Antiqueña by marriage. I am also a Wira. So 3 months after the lockdown in March 2019, I had a miscarriage. So that was my 4th pregnancy due to early fetal demise. And that experience cemented our decision, my husband and myself, to finally avail of family planning. I'm a breastfeeding mom of 6 months, more than 6 months by that time. So obviously I know that I should have family planning already, with my 3rd child. Now then, the question was what to choose. My husband and I, we never liked condoms. I do not think I can be consistent with pills. And DMPA every 3 months during the pandemic is like kind of high risk. So BTL would make me undergo surgery. So also no, that left us with NSV for my husband or implant for me. So his only condition was, give me a list of NSV experts and I will do it. And I could not give any provider. So it was implant. And at the height of the COVID fear, so my husband was tasked to ride his bike and go to the nearest health center. He was told that the doctor who used to do implants in that district health facility in Iloilo City has been transferred to another district health center about 5 kilometers away. So he rode his bike again. He went there and got the schedule. And we went there on the scheduled day. That was a Tuesday. I was told that I cannot be accommodated in the afternoon because they will only accommodate 10 slots and full na siya. And for the next week, I can still not be accommodated because it's also full. No, so good thing I knew of a private clinic, which is IMAP Iloilo, which is actually near my house, but it's just that I wanted to try out the public health system before trying out the private clinic. So I went there. Once in IMAP, I was asked if I had PhilHealth, print my MDR, and in about 30 minutes, I was implanted and with no out of pocket. And I'm going on my second year of implant use now, no, and happy, and happy for that. Thus, the same with our partner provinces. Key factors affecting LARC provision is really the unavailability of actual providers because of insufficient training, or maybe those who were trained already retired, and which is also contributory to misfinancing from PhilHealth. We have one MHO who lost her PTE certificate, and the PTE certificate is a requirement to be PhilHealth accredited, and wala lang. Because it's lost, then no accreditation. So things like that, no? And the public can also supply commodities to the private sector as long as they are available. So with
Bayot, paper naman bayot.
the midwife who was doing the implant on me, and she was saying they have a partnership with the Iloilo City Health Office, and all the FPs being done by IMAP, and as long as they have commodities, the service is free. So if I did not have if there were no implants during that time, I would have had to pay 3,000 pesos for the implant. No? So thus, the critical opportunities for the private sector are really a credible leadership in the provinces as an organized private sector group, private sector representation in the HCPN committee and the Provincial Health Board, capacity building on the UHC law, province-wide health system, and in terms of FP, capacity building as well, considering also Mandana's DTP plans and facilitating the practice of the UHC SHF pooling purchasing. What could be the strategies for commodity security in terms of this? No, initial conversations say that as supplies are purchased at the areas, they are 3 to 4 times more expensive as compared to buying it in bulk at the national level. So what would be the best strategy to help these provinces out, considering that budgets are limited actually? So to end, I salute my colleagues in the provinces, the PHO team, the PIDOHO team, the PhilHealth Leo, and the regional stakeholders for their trust and openness to listen and do despite the uncertainties. So the UHC, Province-wide Health System Integration Reform, is definitely a Herculean task. It just sounds seamless when I share it with you now, but you can only imagine how it is happening on the ground. That needs as many heads and hearts and hands working together to be more steps closer to the kalusugan pangkalahatan, the maayong lawas para sa tanan, and the universal health care for all that we want to achieve. No? So thank you very much for listening.
Dr. Lena, before I ask present his inputs. Just a reminder that cards are there to write questions. I am already very sure that we're not going to make the questions later. So please write them down, even just your comments. So we now listen to Dr.
Thank you, Dr. Ayab. Thank you to everyone. Good afternoon. And my compliment also to the previous two speakers. Thanks to you, I don't have to show so much. I really cut down a lot because it's a huge study. But I really just zoomed in when I was talking with ThinkWell on parang what kind of thinking do we need, what kind of findings do we have from our study that can maybe enlighten our way forward for the mixed health systems or the private participation in health systems. And again, compliments to the previous ones because I think there's some major leaps forward despite the 2-year gap that we've had. So this study is in fact DOH and PhilHealth funded at some point or other during its now 5 or so years in execution. So I've entitled it Network Comprehensive Primary Care for UHC. And just the first word network, I think, comes from our discussions with ThinkWell also, because just that word alone carries so much implications already for patient continuity and the kinds of mechanisms we need. And insights on the role and successful use, and again, a deliberate use of the word use, because really, the private sector even here is just a means. No? The end goal should be UHC to the private sector. So it's a lot to cover, and I was told just 10 minutes. So I'll just dive into an overview of the study so that those of you not familiarize. And just as a lens, I'll focus on one specific aspect. I can say that the study tried intervening and studying pretty much every health system building block. But I'll just look at one, which is medication prescription dispensing, and then from there draw some insights. So it's been a very multidisciplinary group. This is just a subset of the team. I encourage you to think about the way the previous speaker also showed. There's financing, there's policy, there's technology. We developed an electronic medical record system. We pretended to be PhilHealth. That was the research arrangement. We designed the financing and so on. We even went into transportation, logistics, and such. Because it was PhilHealth at the start, the main thing was to design a responsive primary care benefit that would be comprehensive for all Filipinos' health needs. So the concept was, PhilHealth said, we're doing a lot more inpatient insurance. What should we do so that when universal healthcare law comes out, it's very strong in primary care also. But just to do that, we had to show that, as you can see, this is a theory of change. The prerequisites pretty much cover the whole system. So in sequence, the community has to know that they have those rights. So that's community engagement. There's the financing package itself. What are those covered rights? That has to be quite comprehensive and not just a disease-based package. Even if they have the financing and they know and they demand it, it should be able to be supplied. These are all classical lessons that we knew going in just from the literature, just from the history of Philippine health systems. So there should be actual doctors and pharmacies, etc., down there. If all of that is available, we need to track it. It can't be defrauded. It can't be unpaid. So now you need appropriate electronic record systems. We are an archipelago. We have 100 million population, etc. And of course, finally, the most crucial part, the primary care health providers should all, especially in public sector, advocate the same thing. We can't be telling the population one thing and giving them another. And from there flows all the different health system activities that we did in the study. So for example, just to give one example for today's presentation, the drug price reference index, the Philippine National Formulary, those are already existing policies. We put that into an electronic system. The system won't accept prices from a drugstore that are beyond the price regulated. And then we contracted with them to agree to that. Here, you're going to use this, provide your own laptop, here's the software, log in, etc. When a patient comes to you, what do you do? And how do you charge us as the pretend PhilHealth in the study? And there's a rule for the doctors, for the patients, alagaan niyo yung laptop niyo, huwag niyong panakawin yung laptop ng RHU kasi no prescription from the electronic system, no payment. Mag-out of pocket ka. So there's the community aspect right away, and who would have thought that the community education part would fit into an electronic upgrade of a rural area. And then of course the funding, almost as a footnote, no. It's a given, it has to be funded, but how to do it right, that's the trick. So I'm going to skip over a lot of literature, mainly from Dr. Barbara Starfield. This is the primary care model that we use, wherein it's very patient-centric. I've tried to mirror them with these shapes. The basic force that patients shouldn't have to doctor shop, shouldn't have to jump to the hospital right away, to the ER right away. So it has to be a point of first contact with the entire health system rather than be overwhelmed and not knowing where to go. Because it's the first thing that you go to. Quick analogy is your pediatrician when you're a child. You go to them for anything. I had diarrhea, I had eye problems. I go to my pediatrician first. That's your primary. because you go to them as first contact, it could be anything, so it has to be comprehensive, and that's this red circle right here. And because it's comprehensive, it should have access to and coordination with the rest of the service network. And of course, this is generalist and this is specialist. Business could focus on meds, physician could focus on one body system, but you need to use these scarce resources properly. And so there is really a coordination and triaging role. And this is very crucial for the system. And that's why I think it's 1/3 of the UHC law. And kudos to the team for putting together this forum so that we can get on with it. And finally, continuing care. Again, that's why we have networks, so you have the whole spectrum. So very similar, I think, from the study's perspective was as I said, we were told to finance the thing and develop the system. It's like what we're expecting now from UHC law, where the central funding, in this case, usually we think about PhilHealth, we think about UH. But when you have the special health fund in the control of the implementer, it's actually quite local. And going back to Dr. Tan's, one of his first couple of slides, where you have either a local system, that's LGU, or a private system, but that network is local unto itself. So that kind of contracting, it's like we were contracted and then we subcontracted to the network down here. And so primary care was such a good fit for that. So before I go into our pharmaceutical data, we cut our teeth first in Quezon City in UP Health Service. And it was quite ideal because we had 11 family medicine physicians. So we know that the decisions, the medical practice is quite astute. And then we expanded in about a year and a half to a rural site and a GIDA site. Both are municipal class 4, but I think everybody in this room is experienced enough to know that sometimes there are class 4 municipalities that stay there for certain benefits, when actually they're quite advanced already. Regardless, definitely there was a much more advanced rural site than GIDA site. Here there was really a barangay where you need to take a boat sometimes. So you have twice the size here, for example, in the more distant area. It's twice the size, but with 1/3 the population density because it's got fewer people. We were able to add, interestingly, more doctors, although each site started with just one primary care physician in the public sector. Thanks to the funding, part of that went to additional doctors, not just by outright salary, but by earning it back through the services also. So really systemic. I'd like to point out the nurses, midwives in proportions here also that are quite different, because our nurses and midwives could prescribe, could diagnose. I know that's illegal, but our electronic system prevents it from being illegal. Okay, because we had to, it's very locally designed. We know that there are very good tentacles of the doctor there. They know their population, they know certain basic diseases. The electronic system now allows that to be a tentative diagnosis, tentative prescription, shoot it to the doctor in the RHU electronically. The doctor can modify, can add, remove, subtract, give comments, shoot it back in the same few minutes. It doubles as a learning tool. So very, very systemic, and that was very empowering. And it allowed actually the prescription to now be printed because now it's been supervised by the doctor. So you'll see the effects of that also in the prescriptions in my next few slides. So again, zooming in just on the pharmacies, but rest assured we did the same for labs. And we tried for other physicians, but it was very hard also because you're now dealing with workforce practices. But you had here 2 private pharmacies joining the RHU. You had here 3 private pharmacies. Surprisingly, mas marami pa in the distant area. What does it look like? In terms of, just as an overview first, you have here the consultations. This is from our first site, not yet the rural site. Around 1/2 to 1/3 of patients, this is unique patient seen. So a patient seen in this data set might in the next month come out again. But regardless, a consult might have a 1/2 chance to 1/3 chance of resulting in a patient availing of medications. That's the green line here in the monthly sense. Here it is in the cumulative table. So in presenting to you now the pharmaceutical consumption data, we start with, I'm going to show you how many patients were served, already seen encountered at the pharmacy, what line items they were prescribed in the electronic record system, which of those line items and how many were dispensed by the private versus public pharmacies, the quantities of actual pills, tablets, bottles, etc., the value of that, and then we go back full circle to the patient and say, in terms of medications, how much was it on a per capita basis? So starting with the distant area, here are those 6 data sets I've just described. So in patients seen and encountered by the study's pharmacies, you have about 6,000. Remember, we're not counting it the laboratory encounters, the clinic encounters. This is just pharmacies because of lack of time. Because I think it's very compatible with the discussion on private sector participation. So 6,000, almost 7,000 people in 2019, 20, and 2021. Take note, we started mid-year here in 2019. And then by early 2020, we had the lockdowns already. And then we finished in 2021 with, I'll show you a hiatus of the calendar in a short while. So 6,000 in 3 years, distant area. Out of these people, that's about 1.5 line items. So it's paracetamol is 1 line item, losartan is another. So typically 1.5 line items per prescription. This is already dose given in prescriptions. So that's about 10,000. Right away, you see 60% dispensed or seen by the private pharmacies. 100,000 in terms of quantities dispensed, pills, tablets, etc. 150,000, roughly around 2 million. Again, 60 now increasing to around 70% fraction contributed by the private sector. On a per capita basis, that's around, you have now here a gap from 288 per capita in the public side to 398 in the private side. But on the whole, not such a big gap, especially at this scale. And you'll see that across the board, you have an increase. In 2019, 40%, 60, 70. Here, increase also in the fraction provided by the private sector in terms of line items dispensed. That to me is a sign of responsiveness. They can adapt. They can notice, like in 2019, parang marami itong drug na to, kailangan nila kasi mag-stop tayo. By 2019, 2020, 2021, they're giving more of it. They're responding very quickly. And the same increase here, even sharper increase in these proportions. And here's that same data set for the rural area. So similarly, in fact, a little higher, 70, 80% right away at the end, 85, 90%. And the increase from 60 to 90 increases here in proportion over those 3 years in terms of these quantities. But roughly the same 1.5 prescriptions per prescription. So I just want to point out here the zeros. This is for further study. I think we need to impute and recalculate because, and there's the fragmentation being a problem. When the RHU dispenses drugs that it won't charge for because it was maybe downloaded from the OH, they count it as 0. But that's not the true value, the government paid for that. So that's something that we should add there. But I want to point out, take a look at the fractions here in this particular site. It's a very robust rural site. At 90, 85% being prescribed by the private sector or dispensed. Practically, you're expecting low numbers there anyway. Is that the dereliction of duty? I don't think so. I think this highlights already a frame of mind where we need to accept and even encourage and harness and properly guide that the patients get their right to these drugs, to these medicines. If it so happens, it's just one theory, I mean, you can interpret the data in several ways, but if, for example, it's much easier for our networks in our study to have used this system rather than keep procuring, trying to predict, trying to outstock the private sector, and then wasting the drugs because you don't predict accurately, you have to throw away at the end. Whereas you don't have, pretty much, you don't have that wastage when you have the private sector model here. That's not our wastage. They'll restock that somewhere else. So there are those efficiencies despite slight increases. You see here, for example, per capita, very difficult to compare. But I expect a little bit of an increase now. I mean, a little bit of a gap where on a per capita basis, it's more expensive in the private, but that's what you're buying, those efficiencies. So moving on from the money part, we always forget, and I think there's one thing I want to emphasize, it's that the finance part of health systems has to include time, especially when we're talking about private sector. We started the study 2015, 2016. We started rolling out services in UP, the urban side, for this particular graphic representation of 2016 to 17. Take note that the first checks came in around halfway through the study. And we weren't able to pay this UP health service side until around the end of that service coverage year. No private business can survive that. Luckily, this was a government site. So a G2G arrangement, they had their budget. They found a way and just used their budget first. Let's fast forward a year and a half later when we already started funding the rural and GIDA sites, where they're public-private. We waited till the check came in before we started. But also, despite that, we'd run out of money toward the end. Some of the checks here needed clearance, and we couldn't pay our health networks at this point, and so we stopped here. We delayed because of delayed fund clearance. That was the main reason for the delay here. Even if this was already lockdowns, the lockdowns were mainly NCR. So the stopping of services was really, I would say, more of because of the funds, not because of the lockdowns. And also, you'll see that after the lockdowns, when we adapted with telehealth afterwards, tumaas naman ulit yung services. So it was really the funding that stopped the services. So some insights from the time aspect. The pharmacies were added at the start and mid-study. That flexibility was important. May isa pa nga na nag-volunteer. They said they like what's happening in the pharmacy of the study. Pwede ba kami rin? So local small businesses were included. One even set up a satellite. These flexibilities are not as easy if you were purely public. One pharmacy nearly left the network when after 1 month, hindi pa sila bayad. The tolerance is very like 5 days, private sector. In public, regularly sa contract, draft pa lang ng contract, 30 days na. Draft pa lang yun ng contract. We had to make a buffer fund, but that's very tedious. I do not recommend it just to cushion for delays. Just don't have delays. It's not scalable. Electronic transfers are the key. And rest assured, we talked to both public and private banks, and they were willing and capable, already doing it for GSIS, for example. But somehow we couldn't in the health system. There are so many unnecessary steps sometimes that we default to, but won't actually help in paying. We need to shift from that kind of mindset to having automation and transparency first and pay it already, and then audit and punish afterward, maybe. Here it is, one of my latter slides already. You notice that the blue line, the white line is how much was prescribed, public sector. Those are public physicians. The blue line is how much was dispensed. That blue line, the one that's responding to that demand, is the private pharmacies. The orange line is the public RHU pharmacy. Not only is it unable to meet most of that demand and be flexible with it, but also when you have the stoppage, somehow for some reason, both of them actually stop for various reasons. And of course, you don't have time for it. But here's the hiatus I talked about. And then here, you can't see it here so much, but the red line here is the end of the study. And so no financing, no network. And here's my last, I guess, most important graph. The health equity part, the hardest outcome to achieve. It's different when you just throw money at something. Of course, services will increase. But to have services increase faster in targeted areas like the poorer areas, we were able to achieve that. Actually, not seen here is the transportation. We organize transportation a lot more heavily in the rural, in the distant GIDA area. And you notice the gap between the distant households as a proportion of consults versus the, near households versus distant households. The gap went from around 40% to around 20% just in this early segment of the study. So that's very health sector plus, I would say, the health sector plus transport. And public sector plus private, because the drivers associations was very income, that's not, I don't think that's. So insights, we saw the reach of the private sector. Our private pharmacies were all the way out there. I think this allows us to safely think of them as being able to support availability. And I would say also affordability and accessibility in a wide range of areas, even distant ones. We saw the interdependence of success factors from theory of change, the interdisciplinarity of our team. And I would say that the health systems we're trying to build are superorganisms. I didn't go so much into the electronic systems, but that alone shows, I think, the different subsystems that need to work together. So it's required to be multi-sectoral. Health equity effects and the plus factors, I think, to be truly patient-centric, we need that. We can't stop with what we normally deal with in our sector. Transport is just one example. The volume, the sensitivity to demand, the ability to meet more of the demand, I think speaks to the need for the plurality. Again, private sector has to have some competition. That's our safeguard also. Flexibility in contracting. The bidding process, for example, will only give you one winner. I'm noticing some very advanced thinking from previous presentations, something like, I haven't heard too much about framework contracting. I guess that's a hybrid between a regulation and a contract. Something like, okay, you want to join the network, adhere to these. It's almost like accreditation. I look forward to arrangements like that. And the P4 of the PPP Center with LGU, it empowers the LGUs, I think, to do their own kinds of rules for public-private participation. Not untrustworthy as certain news articles recently described. And sensitivity to financing, here's the clincher. If we don't design for it, if we don't finance it, it won't happen. No network. So fast, pure, auditable payments are required. And I think the underlying thing here, next slide, please. My last click. I think this one's more important than we think. We need to be asking, what is the role of the state in this quote-unquote game? We are both player and rule maker. We are both provider and regulator. And so I think we need to expand the space. I think Dr. Tan mentioned it's public-private interactions. But I think if we want something more controlled, more advanced, more harnessed, it has to have a certain participative intent, really. That doesn't quite fit the mold of partnership like the BOT law would say, like a giant project or a giant money-making thing. So there's a frame shift toward shared goals being intended and deliberate, and allocated risks being an intended part of that. So thank you, and looking forward to your questions.
Thank you very much, Dr. Rafi Marfori. Indeed, very robust, very, very full inputs, and we're at our first session only. As we had predicted, we will not be able to entertain many questions, but we can entertain maybe one or two before we proceed to our next session. Those who want to write out their questions and submit to us, it's very welcome. But maybe I'll open the floor for maybe, I have a lot of questions, but my work is to to listen to you, for your questions or concerns. Again, the focus of the first session is to look at where we are. And so Dr. Lester Tana showed us where we are, obviously thinking through a framework that will work. Dr. Lena Lagon-Alvior showed us an experience from a governance perspective. Dr. Marfori showed us an experience that was quite specific. Well, what he chose to share was something to do with private sector performance in relation to medicines, and also giving us already insights. I think this is a lot of input already for, again, discussing this private-public interaction, maybe not yet partnership, but please, if there are anyone who would like to, again, this is not so much questioning our panelists, but of course you are free to do that, but also really entering into some conversation. Also, those online, you are welcome to please type your questions or comments in the chat. Anyone? Yes, Dr. Pat, paabot naman ng mic kay Dr. Chis.
Private enterprises that you modeled earlier, where they I think they will less than 40%, will have that was a very
Because we are sustained by PhilHealth. We do not charge. We are like government in the sense that we work among the poorest and marginalized. But we, unlike government, who have salaries from government agencies, they can charge doubly, di ba? Because they can also charge from PhilHealth. Kami, wala kaming ganyan. Kaya I think in the first presentation, there was an identification that merong mix. That is, I think, where most of us belong. And I think it's unfortunate that you're developing it. but I just wanted to make the point, you need to develop that, hopefully faster. Otherwise, a sector that works in a very important part of health, which is sexual reproductive health, the foundation of maternal care, etc. We will be falling through the cracks because we are different. And I hope that you can pay attention to that also. Even though yung mga pharmacies hindi masyado, no? But the logistics, because parang we're in between, ano ba kami, population ba kami? Because population, in many instances, public health, maternal health, family planning, with all our intergenerational results, parang population talaga siya. Public health ang dating tawag sa kanya. But now we're falling through the cracks. And I'm just worried na all of this can really gloss over yung the focus. I know that we appreciate the focus on universal health care and that we need to standardize. But I think there needs to be appreciation also for the different kinds, I think, of primary services. Kasi yun na nga yung SRH, alam natin primary, and therefore requires a different set of eyes, I think, no, and approach. Thank you very much for listening. Salamat.
Maraming salamat, Dr. Judy, is very well articulated. I think the concerns from the advocates of SRH will share the same concerns for the cancer advocates and all those who are straddling, a population-based and individual-based dilemma. But I think this is also something that perhaps may be considered, as Dr. Lester shared, in this emerging framework where there are different models. Maybe it has to be thought through as well, because certainly this is a commitment of the country. All the SRH targets are country commitments. So that's one input, siguro. Would any of our partners from the DOH want to respond to that very, very quickly? Or
Thank you, Dr. Judis, for your inputs. Yeah, we really acknowledge, and this is just really a realization for us, because when we are talking about this private sector, mostly what we have in mind are the for-profit private sector. But now that you have mentioned what you are doing, and you don't have salaries from government, but you don't also get out-of-pocket payments, and you mostly depend on PhilHealth payments, and therefore we now realize that we have the not-for-profit healthcare providers as well, which are also private but not-for-profit providers. Thank you.
Just siguro, privilege of the moderator, I will ask one question before we move. Are there, especially since our DOH and PhilHealth partners are really the drivers of all of this? I mean, everybody waits for the policy formulation. What is it that is sort of like urgently needed, or where the private sector and groups like ours can really help you so that we can move another step or a couple of steps more in relation to this healthcare provider network and engaging private sector? I think much work has been done with purely public HCPNs. Meron bang pwedeng gawin na para makapasok na yung private sector? I mean, I think there are initiatives that are very local, but is there anything that perhaps private sector groups who are listening now can actually start thinking of already as you are still formulating and finalizing the framework? Yeah. Both big and small now.
Yeah, thank you, Dr. Murphy. Yeah, what we have on our plate right now is we are trying to develop the policy framework or guidelines on how the private sector can engage or participate in public healthcare provider networks, so in the province-wide and city-wide health systems. And the third part of my presentation earlier is just a very initial draft of that policy. And we are really glad that ThinkWell has organized this kind of forum to get more inputs to that. No, I think Dr. Apostol will be presenting later on some inputs to that. I think he has shown some of his some slides on what their thoughts are with regards to private sector, and therefore, yeah, we would really appreciate getting inputs for that policy on private sector engagement in the public sector or in the province-wide and citywide health system. Another policy that we will be developing is the different models, or how the purely private sector can organize themselves as a network, no? Regardless if that would be a single juridical entity or composed of different juridical entities. No? So that is where our study on the purely private networks comes in, and it is really still in the very initial stage pa lang po.
Salamat, Dr. Lester. So, laruin ko lang na ang currency talaga para ubusan ay kung ano man yung lalabas na policy formulations that come from the DOH and PhilHealth. No? And then at the same time, PhilHealth will release all of the mechanisms of purchasing or paying as guided by these. So that's clear, no? That the private sector should really more actively contribute to that already para mapasok yun. But at the same time, to the point of Dr. Melgar, there are certain special programs that really need to be looked at as a unique way to ensure also that there is that participation. Yeah. Director Mamarin, you want to say something? Go ahead, please.
So, good afternoon. Just to answer the question flashed on the screen, there's so many policy gaps right now that we're still on the process of developing. So first and foremost, of course, we have to really define, we were talking about that earlier with Doc Ish, is what will really be placed under population-based and individual-based health services, because it will depend, the financing will depend on what will be classified as individual-based and PhilHealth will finance, and what will be retained in the population-based, DOH and LGU will finance. Aside from that, if the DOH will be continuing to finance that, I think one area that we should also work on in the financing side is really on the public financial management side, because we're having difficulties in terms of how are we going to engage the private sector. By default, we have to go public bidding. I mean, that's the default. We cannot just go talk and then we will contract you like that. At least PhilHealth has the mandate, but for the DOH, on the population side, on the population-based side, and those that are in between that will be retained in the DOH, that's one area that we are having difficulty right now. I mean, in our current affairs, especially we're experiencing it in the research area, we cannot just engage the private sector in doing research. They have to be, they have to. So those are some of in the pipeline where we will be developing the PFM roadmap, and we plan to engage the COA, the DBM on this, so that we will be guided on how we can engage the private sector, especially if we will be continuing procuring, although that's a very good question coming from Dr. Marfori. Is the DOH still procuring, or should we just provide funding for the private pharmacy? So that's a thinking point for us. We still have to define it in the Department of Health, but right now we have the devolution transition plan, which already specified what will be or what type of LGUs we continually supporting on as regards to commodities. So there are so many things that we have to trash out until now. Yeah, thank you.
Salamat, Frances. But quick question. Kahit sa UHC integration sites, hindi pwedeng hindi sumunod sa mga patakaran at batayan ng COA. Hindi pwede.
Hindi pa po, ma'am. Kailangan pa talaga ng panibagong guidelines.
So to be able to tell private sector, let's try out your model in an integration site kasi parang sandbox yun eh. Hindi pwede, walang ganyan.
Sige, Doc.
Sige, hawakan mo na ito. Susunod ka na naman eh.
Good afternoon po. Well, yeah, for example, in the release of money, the payment side, financing. Although what we want really is to test the reform on a prospective type of payment, either a prepayment for that matter, still we have to discuss it with the COA, because that is a government fund being provided or paid to the services provided by the facilities. So as of now, that is one of the stumbling block for us to come out with the policy on, particularly on the provider payment mechanism. Because we still have to make sure that the COA will come out with accounting and auditing guidelines aligned with what we want to achieve as a reform in the provider, in the prospective payment side. Otherwise, lagot kami. Because the current COA rule still is pay after the services.
Okay. But you promised to look into that now.
We are actually having close discussions. I mean, close meaning we are regular discussions with the COA. Good, because they are now open to the idea that there is such thing as a prospective prepayment type, especially in health. And so what they are waiting right now is for us to come out with a policy and for them to make the necessary accounting and auditing guidelines. So it's a positive improvement as we speak right now.
Thank
on
you.
our side, yes.
Thank you very much. And on that note, we'll move on now to our second session, which is really exactly as what Dr. Parga started to share with us. Despite all of the seeming challenges and the darkness that we face with all of these, there are options and opportunities. No? So we listen to three speakers here. Dr. Pargas will talk about options for contracting of private providers. Then we will listen to Dr. Banzon, who will present to us also how we can explore private-public partnerships. And we will listen to Dr. Apostol, who will again share a ThinkWell perspective on this. So go ahead, Dr. Pargas.
Again, good afternoon, everyone. Backgrounder lang po, no? Actually, just to put it into context, gaya ng nabanggit na kanina ni Lester and all, we are actually dependent. There are several dependencies for us to come out with the guidelines on how to actually contract healthcare providers. Not only the private, but also with the public and the mixed public and private networks. Because we really want to, the health system has to develop and has to integrate itself as a network before we can actually contract, because that's the principle behind the UHC. And so looking into it right now, we know that an integrated network would constitute the primary healthcare services up to the tertiary care services, or that's for the services on the facility side, it will be the primary care providers up to level 3 of facilities. And then of course, outside the realm is the apex. But as earlier, the norm is really in a province, there is a primary up to level 3. But as identified also, even at the public side, as identified by Dr. Lester earlier, there are provinces which only has primary care and level 1 hospital. So in effect, how can you follow the rules set by the UHC that an integrated in a province is a primary up to level 3? So again, we need to wait for the design of the integrated network of facilities and services, or a framework from the Department of Health, because Guimaras is a level 1 facility and primary care. But as designed again in the UHC, we are to pay the global budget to the integrated network for them to provide primary to tertiary care of services, or primary to level 3. And that is designed within a city or within the province. But this time, it cannot be, because the whole province is only up to level 1. So there will be probably another design for a inter-province, province to province integrated, because again, the contractual agreement or arrangement can be Guimaras province can have a contract with another province for them to provide a level 2 or level 3 facility. Again, another contract arrangement for an apex hospital. That could also go to not only on the public, Because even in Guimaras, I was asking PV, is there any private? Because if there's a private level 2 or level 3 in Guimaras, then technically there is a complete integrated network, mixed public and private as designed. Pero kung wala rin, then even the private, hindi rin mabubuo yung integrated network of services. So I think that's also one of takeaways na baka kailangan i-design ng policy framework and design ng integration of health services and facilities ng Department of Health. And we would be needing that actually because those are some of the inputs before we can actually design the contract or how we will actually contract the said network. As it is, gaya ng nabanggit kanina, sorry, next slide. Yan po. Ayan. So ang basis natin really is to shift from what we are doing right now, which is accreditation per facility service. Di ba ngayon ang accreditation namin is per service? So MCP, we accredit for your service. Hospital, we accredit for service. Per facility, but right now we will endeavor to contract instead of accredit public, a private, or a mixed healthcare, again, provider networks for the delivery of the identified individual-based health services. So yun yung mga pinaka-importante. We are shifting now from accreditation to a contract. We are shifting this from an individual to a network. And of course, we will be focusing for individual-based health services. So far, what we have designed are the minimums because for other specific qualification criteria, we really need to check on the design and framework of the networks that will be modeled under the Department of Health. So yung integration is on 3 areas: technical, managerial, and financial. So far, what are some of the identified? This is a moving or a work in progress. There are so far 7 technical criteria identified. For example, in a technical criteria, of course, there should be a defined population that it will serve. Why? Because as pointed out earlier, the design of the UHC is that the primary care and the primary care providers is the initial point of contact. And the initial point of contact now will have registration of every Filipino. However, there are some limitations with that because per provider or per facility, primary care provider facility, we do have a standard of how many beneficiaries or how many in a population can a particular provider can serve. For example, right now yata the standard is 1 doctor is to 20,000. So technically, you would have a defined population coverage, which we would need. Second, it's a defined population because the health system is being designed as a province-wide again and a city-wide. And that the treatment and the referral is upwards or downwards. It can be horizontal to another integrated or to an apex which does not belong to the same. But kung meron ka na kasing province-wide and it is designed to have a primary and a tertiary care, ibig sabihin, most, if not all of the services should be there. Ang wala na lang is the most complicated, which is provided by the apex. So technically, the definition of the population is with the province or within the city. Of course, the defined services, set of defined basic services. And of course, as identified, primary to tertiary care. Again, the design of the UHC is that the patient can go up through a referral or could go down through a referral because Going back to the principle that the primary care is the initial consult or the first consult, sila ang mag-aalaga. Pupunta lang sila sa ospital kung kailangan, kung nai-refer, kung ang serbisyo ay doon may bibigay at hindi sa primary care. Pero pag naibigay na, babalik ulit. So there should be this patient navigation, policies and procedures. And of course, although of course, meron mga special situations like emergencies. Coordination of care, ganun din po yun. So it's a dual referral system and of course, should have a mechanism for care beyond the facility-based and promote continuity of care. Because basically, there are services that does not need to be done in a facility-based. Pwede naman kasi katulad halimbawa, ang rehab, pwede naman hindi sa isang ospital lang. Pwede in another different facility, although facility-based, pero hindi siya fixed in a hospital lang. Which can also be part of a primary care, like the rehab. So meron po tayo mga na-identify na ganyan. And so for example, for managerial criteria, sorry, hindi pala nag-move sa akin down. So part of the managerial criteria, the governance criteria would be there is a license and accreditation. Although meron po akong naging isang issue doon sa DOH 2020 something AO, licensing and accreditation. Ang nakalagay kasi doon is technically ito po, DOH license and or PhilHealth accreditation. Because the idea or the intent really under the UHC is for the DOH to license or certify, particularly for the primary care, and for PhilHealth to contract. Wala na kasi pinag-uusapang accreditation. It is already the contracting. However, we will require a performance contract. We will contract for the whole, or we will contract the whole network. And what we will actually require sa bawat facility is a performance contract. Hindi na natin kailangan i-accredit uli sila ng hiwa-hiwalay and then we will contract the network because nagdo-double lang tayo ng mga proseso. So, di ba meron kayo performance commitment? So, yun po yun because we need to see and we need to know that the facilities will actually deliver. But the contract, of course, the whole contract, especially for the payment and all, is within the or with the network. Of course, there will be criteria for human resources. This has been identified with by the Department of Health as required. We will do performance monitoring because again, nasa batas po kasi that we should be paying, which is our function, on a performance-based or resource-based. So kaya kailangan po natin yan. So we will be shifting from inputs to outputs as part of our monitoring. But coupled with this is of course the provision of incentives, integrated information system, nabanggit na yan kanina po ni Lester, and the DOH and PhilHealth is currently doing this thing. And of course, well, the patient's privacy and confidentiality. Pagdating naman po sa financial criteria, sorry. Yeah. Well, ito yung nabanggit kanina. Still, we are waiting for the framework on whether it will be a single juridical personality or whatever juridical personality para makapagbayad po tayo. So this will be on how the private network or even how a public and private network can actually form that network and have a personality na bayadan natin. Because di po ba sinasabi ngayon sa batas is that we will pay the network and the board of the network will actually manage the fund. So doon natin i-release yung pera. As a government entity, we need that personality kung kanino natin siya ibabayad. And of course, part of those requirements would be for or under the fiscal authority. Pooled funds at the network level. So dapat meron po mga mechanism at the network level ng accounting and all those financial management. which is an issue earlier raised by Director Mamaril and Lester dun sa kanilang initial findings with the private. Has a network-wide investment plan because that is one of the reasons why we do want to reform the provider payment also. Is because we want the network to have to plan ahead on investing, on their procurement, on their supply and all. And because we will give the money ahead, they can better plan and make sure that they can provide all the services. And of course, the menu of charges, which is implemented across the network, which again is although I think there's a finding directly Lester kanina with the other private provider network, the menu of charges is common across naman in a particular network. But again, coming out with the contracting, we will need the policy framework and guidance on how these networks will be arranged because specific for the private, kung makikita niyo po sa pinakita kanina ni Doc Lester, surely there will be different models that will come out. Iba kasi yun sa government one because it's within the province and within the city. Pero meron pa rin tayong issue, baka magkaroon ng inter-province. Because of the, again, hindi kompleto yung facilities and services. Pero yung pinipresent kanina sa private is because it's market-based. Meron mga network of facilities na hindi vertical in a province ang presence, but owned by one institution pero in all places. Yung typology ng ating network na present ngayon for private is different. For example, Mount Grace. Ang presence ng Mount Grace is hindi lang isang probinsya. Ang presence ng Mount Grace network is in different provinces. Pero kung titingnan mo, ang network niya ng facilities ay mostly tertiary. So, hahanapan natin siya ngayon ng paano yung secondary, paano yung level 1, paano yung primary. What? Are they willing to form a network with other owners, with other networks? Qualimed, it has a hospital, it has a primary care. So kung titingnan mo, uy, mukhang kompleto siya. But may level 1 ba siya? May level 2 ba siya? Again, to follow the rules ng integrated service and facilities. And thirdly is, may mga facilities naman like Ayala. Mostly primary care naman siya. So, again, in different areas. So, pwede siya maging primary care network, pero yung integrated, willing ba siya na ipag-partner in the medical city, for example? So, may mga ganun pa rin tayong models na kailangan tingnan. It is not just the plain as defined in the rules or in the UHC right now. So far, yan po yung ating mga dependencies, and as a work plan for contracting, kung magkakaroon na ng mga dependencies na yun sa policies, right now po in 2022, we are doing the preparatory activities, and this is part of the activity, the consultation with partners, because we are now getting all your inputs, being providers, especially from the private. In 2023, we are to hopefully come out with the contracting guidelines already. We will do the orientation, and of course, we will already conduct the self-assessment of all the possible networks, of private networks, and even the public. And hopefully by 2024, we can do the pilot testing. And of course, we are looking at 2024 and 25 as our pivotal year for the implementation. Now, as an example, to test, yung po nabanggit kanina ni Dr. Marifea, is the sandbox. We want to test this in an environment, particularly the reforms ng UHC, network, contract, and the payment, SHF. And so we are looking into using the consulta first, and the network would be primary care provider networks. So this will be the different consulta providers in an area to form a network. And when they do that, we will contract that particular network. And of course, we will test the special health fund or the capitation. So that is one thing that we are trying to do right now, and ThinkWell is supporting us. And USAID is supporting us also on that. And hopefully next week we will finalize the policy issuance on this. And as part of the preparatory activities, there are technical assistances from different development partners, especially for them to guide us on how we will proceed with the development of such policies. And again, the dependencies. So far, yan po yung status na ginagawa sa ngayon. But this is a very welcome activity for us as an input for our development. Thank you.
Thank you very much, Dr. Ish. Kahit pa kung hindi ka lang naman. Diba? Sige. Following the input from Dr. Vargas, Dr. Doto Banzon will join us online, and we are asking him to give us more possibilities. How do we explore this public-private partnership for private sector contracting? No?
Can you hear me? Narinig po ako?
In the meantime, I think snacks are there.
Narinig po ako? Maaf. Yeah, I'm unmuted on video. Can you? Narinig ba ako? Maaf, I'm here.
Here in Zoom, we can hear you though.
Yeah. So I'm heard in Zoom, but not with face to face, which is good. So I could just talk with the Zoomers, not with the. Yeah, the boomers, the baby boomers cannot hear me. The Zoom. Narinig daw ako sa Zoom, Maf. Nice na.
So, can you say something? We'll see.
Yeah, good afternoon. Good afternoon, everyone. I think I'm.
Okay, go ahead.
Yeah. Sorry. So, okay, got 10 minutes, so I won't be doing a press slide. And first of all, good afternoon, everyone. Nice to be talking here. I think one of the things we miss sometimes when we talk about public-private partnership is in a sense in the Philippines, the context of how is the private sector the role. How does the society, the government has treated the private sector historically, and I think the Philippines uniquely not uniquely, because a lot of other countries are doing it. Historically, we have always involved the private sector in the delivery of health services. The private practice of doctors practicing outside of government hospitals, that's never been banned. There's never been restrictions in medical schools in the Philippines where you have the government deciding how many schools should be there, how many should be enrolled. So we've always had the private sector involved in the production of health workers, doctors, nurses, and everyone. The setting up of private hospitals have always been an accepted approach. That means we've always seen private health sector as part of how healthcare will be provided. Probably influenced by other countries, other societies, where a lot of leaders in the health sector historically were trained. So and as we look at it, so given a setting where you have the private sector considered as part of the services, the delivery of services, there's always been engagement, whatever you call it, partnership, engagement, working together between the private sector and government. People sometimes forget that PhilHealth, PHIC historically started in Medicare. It was essentially an effort way back in the 70s to get people who were in members of GSIS and SSS better access to private hospitals. And in a sense, the clamor for Medicare was I think significantly driven by that, because at that point, given that it was accepted that the private providers, the private hospitals, the private doctors was part of the healthcare delivery system, which the Philippines considers healthcare delivery system. So people were asking for that access. And so as we move forward, for example, with how Medicare evolved into PHIC and now what's within the UHC law, we've always involved the private sector. Okay, so when you start talking about BPPs, I advise that instead of looking at something new, it's something that's been historically there. When one looks at how the Philippines approach to UHC is, unlike other countries, they approach UHC by really having a focus on purely a government play. That means it's government provision. Some countries even, in a sense, if you nationalize, right? Look, the start of UK, or the way the Thais is. Okay, the UC system of Thailand basically minimally engage the private sector. Okay, most of the hospitals that are contracted by the UCS are government hospitals, the MOP, the Ministry of Public Health hospitals, and the other government hospitals, not in the Philippines. So we've always been involving the private sector. So you said, you get to read the UHC law. It's there, right? It's now there are interesting ways in which we start talking about, okay, so in a sense, how are we gonna engage the private sector? You have historically the private sector being mandated to provide 10% of their beds as charity hospitals. It's now carried over now as basic accommodations. Okay, so same logic. Basically, the private sector is being mandated, right, to make sure that it contributes to UHC. And within the UHC law, you have there's still a number of provisions that actually mandates, okay, so requires the private sector. So from talking to government, I think part of the challenge to the government agencies implementing UHC is to what extent will you be implementing these provisions? Okay. Now, of course, there's no provisions as well, which I think has been discussed quite earlier, about getting the private sector as partners, okay, with the other local governments. Okay, I think that's something that's a little bit new now at this point. So as the private sector starts talking to the implement this provision of the law, where you're supposed to be partners in healthcare provider networks. Now, the partnership between PhilHealth and the private sector, there's a lot of history there. That's something that the private sector and PHIC knows. It's a nice contractual relationship, no need for procurement and all that. I think the challenge there really is how to move forward from the traditional fee-for-service or even the case payment now into much more creative ways in paying. I think that's been discussed already by a previous speaker. But now the challenge now is how to get the LGUs work with the private sector. Now, historically at care delivery, how it's been done? We used to have a nice word for that, right? Outsource, right? That's how the private sector bring in X-rays, CT scans, laboratories, where they basically bring in the private partner. Usually, the location is in the hospital of the private sector and the private of the government hospital, and you come in there. What's bad about that? Well, it's mostly inconsistent with UHC, because the way the payment methods here, the way it's actually the services are being paid, is very similar to how we do tollways, and all that. The user has to pay. And so if this is something that you want to do, basically you bring in the private sector, you contract the private hospital, and then the payment scheme is to user fees. That's easy to do, right? Doesn't probably require procurement because that's you're not spending anything. You could actually even use the PPP loader, but the question is user fees, having a revenue stream of user fees for the patients that will be accessing the private services, the right way to go. Okay, because if you start reflecting on these PPPs, the highways and all that, essentially it's a government. It's essentially the government getting the private sector to put money upfront on the promise that they will give a revenue stream to this to these private partners. So that's PPP. It's a financing thing. That's why you have to go to procurement. Now, it's easy to do that for roads, right? It's easy to justify that as a society because there's no such thing as a universal road coverage or universal skyway coverage. There's UHC. So to design schemes like that where you're in the private sector and you then say it's a user fee story would not be good. And I think that's been the criticism of some of the attempts, right? The Philippine Orthopedic Hospital, 90% of the beds were supposed to be user fees. I think that became problematic. So the challenge really is that may not be the way to go. So you try to find other ways. What's the other ways in which they do PPPs? Let's look at the education school building project. And so basically school building project is also a financing approach. Okay, so basically government contract. Government cannot build the school buildings immediately. So they contract, they did a PPP, I think Megawide that got the project, and this private company built the schools upfront. So it's faster, and the private company used the money. Then the payment basically was annual payment paid by government because you can't do user fees in education. Is this something that the LGU is willing to do or government is willing to do? Where you basically commit to pay. So it's actually like borrowing from your private partner. So is this something that in the health sector we can do? I think it's probably a better fit than user fees. Has it actually been done in the health sector in the Philippines? Not that I'm aware of. It's been done in other countries, where basically the PPP arrangement is the government commits to pay an X amount of money to the private partner. It's been done in other sectors, energy. And so the way they do it with power plants is that if the user fees do not reach a certain amount, the remaining amount is going to be paid by government. The original MRT contract was designed as such. So that's something and if we look at a lot of other countries, as I said, this is the way they do it because they have the flexibility in their financial management and budgeting to commit, let's say for the next 10 years, that we will be paying the private partner this money. Now, some other countries actually use the insurance system. That means they sort of guarantee that their insurance payment will be the one that will go to the private partner. And the private partner is willing to take that risk, that revenue stream from the insurance will be able to go there. So I think this is the one that we need to study some more because the way I look at it, the partnership that can happen. If the expectation is that the private partner comes in and will be partnering with the local, with the network, and the funds flow goes to the network, then you need to find a way where you can guarantee X amount of money that goes to the private partner so that the private partner can invest, be willing to be partner with you because they're assured that they'll be paid for whatever investment they're going to put up front. I don't think there's much thinking right now that's happening on this. There's still some user fee thinking, which I think is not really, it's not consistent. Again, as I said, with UHC. So I think that's why to do it. So another reason you also do PPP besides financing, so in a sense, because you want to put the services ready and you don't have the money to pay for that, so you bring the private sector. It's flexibility because there are certain services in the health sector, in health, which is difficult for government to provide given the way government budgeting rules and financial management rules. Or in a sense, a recognition that government does just have the ability to upgrade, to update quickly. Okay, so for example, a lot of diagnostics or certain other services, basically the obsolescence is quite fast. They're quickly doesn't work anymore. So the government approach where they procure, then they hire people to do the job, they get a budget for maintenance, just want work to provide the services. That's why they contract with the private sector because they know that the private sector has the flexibility to do that and can actually put that in place quite fast. So again, the question is how would government, what's the contracting deal? If the private provider, if it's going to be a user fee story, so I keep on repeating this because I'm just afraid that that's how it's going to be seen. It's going to be a user fee story that you say, they can just charge the patient inconsistent with UHC. If it's going to be, that means they need to explore the other ways in which government can pay. So a commitment to pay for the next 10 years, would that work? A commitment to assign your PhilHealth reimbursement to them, that could be another way. There might be other ways, more creative ways that we have to think of in order to have public-private partnership. I think I'll stop there, Marfe. Thank you.
Thank you, Dr. Dodo. Can you stay on until after Jello speaks? So if there is a
Yeah,
question,
yeah, I'll stay. I cannot say no to ThinkWell.
thank you very much.
My next meeting is around 4 o'clock, so probably I'm only up to 4.
Yeah, we try to keep you there. So we have options. We've already heard from Dr. Pardas. There are a couple of interesting ideas being put forward. And now call on Dr. Jello Sol for his input related to options for private sector engagement. But this is more specific to family planning.
Yes, ma'am. So actually, our part of the presentation is really this part of our conversation is really our way of sharing to you how we have also journeyed with our partner provinces when it comes to really asking the same questions that we have been asking ever since we started the stakeholder forum. How can we contract and engage these private providers at the local government level? As mentioned by Dr. Manson earlier, public-private partnerships, private sector contracting has been done extensively at the national level by national agencies. But this time with the Universal Healthcare Law, we are opening this opportunity for provincial governments to engage to contract private providers and for health projects, which has not been done extensively before. And this is something that we have significantly found in our two partner provinces of Guimaras. They have not engaged. Well, some of them, PSC, for example, have engaged with PPPs, but definitely not for them. And neither of them have engaged with PPPs for health projects as far as they can remember. So before we present any models, and when we say models, these are not models that we're trying to propose as standard templates for everyone. And I know Dr. Lester Tan mentioned that it would be good to have standard models, standard templates. But at the end of the day, PPPs are not template driven; they're needs driven. And the design of these PPPs would always go back to the needs that we try to address, and the rationale of why these are being contracted out to the private sector. So before we proceed with that one, next slide, thank you. Sana po ay nakakakain kayo ng mabuti. This is a very good hour. But when we went part to provinces that we give us, we tried to assess in a very academic fashion. And this is initially in a very academic fashion what their readiness was for engaging the private sector. And we are very thankful that our partners from USAID are here, Dr. Joseph Tachita, of course, Dr. Yoli Oliveros, who have supported us and funded this study to allow us to explore options and assess the readiness of both public and private sectors to engage private providers. And one of the things we found, the readiness and even willingness for private sector engagement in HCPNs, in mixed HCPNs in particular, has been highly variable, but genuinely good. Okay? And when we say we assess readiness, readiness of both public and private sectors at the provincial level to engage in okay, sige. When we say we try to assess the readiness of both provincial public and private stakeholders when it comes to engaging private providers in HCPNs, we look at their awareness of PPPs or private sector engagement models, their private sector engagement knowledge, availability of resources, engaging PPPs, for example. Do they have the capital assets, service capacity to pursue these initiatives, these joint initiatives? Do they have the technical know-how, the ability to design, operationalize, execute contracts that involve the private sector, assume risk? Because these projects, these PPPs may involve a lot of risk, and risk that has to be allocated between the parties involved. So we look at these things, and yeah, the result is both public and private sectors. And we do not want to generalize it in all provinces, at least our two partner provinces. It's very, very low, no? Very limited knowledge, very limited technical know-how, very limited access to implementing mechanisms. How do we go about this? The law, we have been receiving these administrative orders from the Department of Health. The private sector can be engaged in HCPNs, but where do we even begin? So, doon po talaga nagagaling. At yun din po yung nakita din namin. No? And one of the things that, so the next thing I would ask them is, how do you proceed from here? And one of the humblest things that I heard from our partner PHOs is that maybe you can do this developmental. And I think there's value in that. I mean, many of these provinces, and perhaps I can speak for the two partner provinces that we're working on. They have practically zero experience. And we cannot just expect them to launch large and hard PPPs overnight, or maybe even, see, for example, if Dr. Parga says that we're trying to pilot this by 2023, 2024, we can't expect them to launch even hard PPPs for health, for HCPNs, even within the span of 2 years. So I think there's value in maybe a future development. And that's what actually led us to our first, we don't want to call this a model, no, but this has been a tool that we have co-developed with our partner provinces to assess the different options. So first, to know what options they have for engaging the private sector and how they might be able to approach it developmentally, depending on their readiness. And also, bringing to bear their knowledge as to how much of the risk, responsibilities, and benefits they can transfer or even share with the private sector. So yung dalawang axis natin, tama? Quadrants, X and Y. Sorry. So kung mapapansin niyo po dito, no, we've actually identified 4 different types of private sector engagement opportunities here. The most basic of which would, for in cases where the public sector is not ready for it, and even though the private sector is not ready to assume risk, to take on additional responsibilities, we can in fact explore non-contractual arrangements. And there are so many options here, no? Everything from patient referral agreements. We do have that in FP, no? These MOU between private midwives and referring OBs and physicians. That's a patient referral agreement. Donations, medical missions, technical assistance, and even service learning arrangements. Where, say, for example, health facilities or provincial hospitals can partner with universities, and interns, trainees can go to these universities so that, on the one hand, these students, they get educational exposure, but at the same time, these facilities, they receive some sort of service augmentation from the students. So baby steps, maybe we can start with this because they haven't even tried this before. And then we have the usual. What is the usual practice right now? We have what we call public-private interactions. No? So this is the usual public procurement of goods, services, through service contracts, through management contracts. We call them public-private interactions and not necessarily public-private partnerships because there's no significant transfer of responsibility and risk. No? So say, for example, I execute a service contract by hiring an OB-GYN, no? Or sorry, an additional midwife to help augment the provision of LARCs and DPLs in my municipality. That service contract, that's simply limited to the provision of clinical services. No? So it's not the entire FP service delivery. So it's just part of it. So there's no significant transfer of responsibility. And the risk is still is being borne by the public sector and not by the private contractor. And then we have itong mga public-private partnerships. So Dr. Noldo has already mentioned joint ventures, leases, concessions, build, operate, and transfer. So in these cases, there is a clear transfer of responsibility. More often, if not significantly, sometimes even all, no? Especially when we talk about concessions and leases. Doc Ish mentioned performance contracts. So in a way, medyo hybrid na rin po yun, but because there are certain expectations in performance contract, there's the position of responsibility and risk on the private sector proponent. But I think, and this is where we really like to thank din po the work of Dr. Dodo Banzon in their 2016 central work, and also the Global Healthcare Group, wherein they even introduced a higher kind of activities, which would be public-private investments, partnerships for health. And I think one of, in our interpretation, and at least in the understanding of our partner provinces, these PPIPs are not usually PPIs in such that, and we highlight here certain characteristics of PPIPs. But in general, PPIPs are separate or distinct from smaller or minor PPPs in that they are longer term, they are highly structured relationships between the public and the private sector, and they cut across different components of the system so that they can actually even provide system-wide efficiency gains. So, and we are thinking that this is our blue sky here. This is the goal that eventually we are able to pursue these kinds of projects that not only involve engaging private providers in service delivery tools. For example, engaging the private sector in managing your health information system, which also has been a model for many other NGOs. Thank you, Jana. But I think there is something to also learn what the team of Dr. Marfori at UPPGH has done. That for me, based on what I've listened to, is an example of PPIP. Not only did it cover one aspect of the health system, not only did it involve engaging the private sector in one building block of the health system, usually service delivery, but to try to cover even sustainable supply, ensuring sustainability of supply chains. We try to even cover health information system. So, and I think this is what I think if you were to really dream about it, and if you truly want transformation and not just complementation from the private sector, I think this our eyes should be on this price. And this is something that we heard. This is not something that we impose on our partners, no, but this is also something that we got ourselves from listening to and conversing with our provincial partners in Guimaras. That if you kung mangangarap naman lang tayo, diba? Hindi na lang complementation of the private sector ang push for natin. Maybe parang we can even leverage all these PPIPs to even usher in transformative changes in the health system and gain this system-wide efficiency gains. So, in the interest of time, we've outlined some of the key features, also building on the work of the Global Healthcare Group and the work of Dr. Banzo. But we've also introduced certain modifications, also based on our inputs from our local partners. Definitely, PPIPs, integrated PPIPs should support PHC. It should be end-to-end, private sector involvement, not only in building, transferring, and operating, which is our usual model, but everything from co-designing, co-building, co-financing, operating, delivering, and maintenance. We started with just 3 typologies or areas, although we appreciate po yung pinasentering with Dr. Lester na it's not just about engaging the private sector in the areas of clinical support services such as laboratory, pharmacy, and non-clinical, yung waste management, supply chain management, but even in standards development, even in the provision of population-based services. So we will include a more detailed description of each of these key features in the policy brief that we will be sharing to you after this program, because I believe that I only have 2 minutes left. But before I move on, I'd like to just discuss very briefly number 7, strategic risk allocation. I think one of the things that we can definitely try to work out on is the usual model of the PPP is that you risk transfer. And then Dr. Marfori introduced to us the idea of risk sharing. But I think we also are to introduce accountability mechanisms there. I think we might also want to think about strategic risk allocation. There is risk sharing, but we also want to make sure that the risk is being borne by the one who can manage it well. Sorry, goal sharing and risk allocation. Thank you very much. So, ito po, again, we are not trying to espouse any models. But one of the things that we found it very easy to facilitate the brainstorming with our, sabi ko nga po, ang pinagsisimulan natin ngayon is that our PLGUs, we have no idea how to do it. But one of the simplest activity that we have tried to discover is to go back to that BBFODM model. No, so there are prototype projects, and then to identify the type of contracts in general, and then try to identify quite simply who designs it, who builds it, who finances it, who operates it, who delivers it, who maintains it. There are so many possible. I think it's not the template contracts here. It's really being able to figure out, at the very least, who does what at each step of the DBFO, DM. Kasi I can tell you, pwedeng lease yan, pwedeng BOT yan, pwedeng BPO, pwedeng any variant. And you can have so many possible combinations of who does what at each step or component of the DBFO DM model. But also repayment. And in fact, I was talking about repayment. This is the part where even us, with very little guidance, and which is why we're glad that Dr. Ishmargas is here, because we agree with Dr. Banzon, especially if you go back here that integrated PPPs at the very least should be cost neutral to patients. If we are to implement PPPs, they should not come at additional cost to our patients. But when we say cost neutral, they should also be cost neutral to the government. It means that if we are to implement these PPPs, it will be predictable for government, whatever payments or repayments they will have if they were to engage in this. So the repayment, we're just presenting it as a presentation of what we think is a reinforcement of the status quo. But we agree with Dr. Banzi, definitely, whatever repayment scheme will be designed should be at the end of the day cost neutral to the patients and cost neutral to the government. We will no longer go through this process, but this was adapted from the Public-Private Partnership Center, which we have also been working very closely over the past few weeks. So it's really a more pastoral approach to helping PLGUs. Not just design contracts, but really to do it properly. If they were to do it the first time, we'd want to make sure that they do it properly and not take any shortcuts. But also taking into consideration that these are provincial LGUs, not all PLGUs can do an honest to goodness feasibility assessment. Because a feasibility assessment, for example, under pre-investment and feasibility studies, that money, they may not have access to experts, for example. So we modified this also take into consideration the capabilities of our PLG. So, we will share this book. We have yet to embark on this process with our partner LGUs in Guimaras. And we are anticipating that this will change. But at least, parang having introduced to them the concept, this is the process that we are thinking of undergoing. So, yun lamang po, the starting point is really both needs and demand assessment. We start from that, but also internal capacity assessment. Yung LGU na mag-execute ng PPP engagement or private sector engagement contract or arrangement, do they have the mandate? Do they have the relevant resources? That's expected, concept development, investment studies, and then we do make a differentiation also between stakeholder consultation and market sounding. Because I think market sounding goes beyond the usual stakeholder analysis, but also really asking very specific inquiries to the potential private sector partners. And then PPP structuring is similar to what we showed you earlier across the DBFO, DM model, performance specification, so that we can monitor and demand high level of performance, and lastly, contracting. Yun lamang po. I'd like to end by saying that when we came into this project, we read all the laws that there were. We looked at all the possible models, publications from ATV about PPPs for health from the PPP Center. But I think it's really these models that have been absorbed and reinterpreted by our partner LGUs that truly made more sense to us. And I think there's value in that. Not simply imposing models on them, but offering this to them as reference and then discovering the inherent genius that they may have when it comes to, seeing how they can take this further. Because at the end of the day, sila rin naman po ang mag-execute ng mga private sector engagement strategies na ito. Yun lamang po. Good morning. Thank you.
Good afternoon. Maraming salamat. Thank you to all our speakers, Dr. Pargas, Dr. Manzon, Dr. Apostol. Once again, it's too rich. And we wish we could, really talk about all of these possibilities. But maybe we can take one question or two, or maybe a comment or feedback with the presentation. Yes, Rafi, please go ahead.
Thank you to all the speakers for enabling and very. Regarding Dr. Ban's content, actually very well expounded by Dr. I fully agree that it's easy to justify private participation now, not just as a society, but I think as an industry. The reason I say that is another of my projects I don't have time to go into is the public-private partnership. And what we're finding is, because we're so complex, kung importante yung PPP sa roads, isang transaction lang yun, you buy a ticket, you go on the road. We in healthcare, we have human health workforce problem. The competition is global, not just rural to urban migration. We have so many other problems, like electronic systems, privacy, credit card na lang, hirap ipa-implement the public policy. So all of these things, all these moving parts, I would say, it was so important to justify that in describing our project in authority. Similar to the experiences we have served with educating co-op, for example. I just want to reinforce what Dr. Ban was saying. I think we need to, I know that narrative really needs to be allocated more to our economic and financial planners. Because the overall attitude, sometimes it swings, it's a pendulum, but at its worst, it can be very hostile. And that's why I put in my slide something like, we have to recognize that we are not just regulators, but to be suspicious and guarding the public first. That's well and good, we're good at that. But we also have to be cognizant that we are trying to foster, and I want to use the word enterprise. When we talk about the shared goals, I think I have a foundation called shared goals. Shared value. That's what I'm talking about, a common enterprise that we are trying to achieve health for all Filipinos, and that's why it's so inclusive to any disease agenda map. And then it's just different players, and then that's when you realize you risk sharing. Not sharing, but allocation. So I just want to emphasize that it's so important.
Thank you very much. Just quick reactions, I guess, both from Dr. Dr. Mamaril, specific to there are suggestions that are being placed here. I know from what Dr. Ish has shared with us, things are in the pipeline. It's a little slow, but conversations are happening. We hear these options, no? There are these models, and we heard Dr. Dodok say, we work with what we already know in terms of experience. What's the forecast in the forthcoming? I know that you said, Dr. Pargas, that 2023 but is there, you think, a way where we can kind of bridge these gaps quicker, and how can private sector help there? So maybe something like that, feedback from that. And then for Director Mamaril, I'm sorry, but I'm going to bring in the theory of change here, which I know this hotel has been venue for consultation. You're hearing this, you're seeing this. Where does this fall into since the theory of change is going to inform the national objectives for the next 6 years. So maybe those two questions, Jack and Poy, kayo kung sino gustong mauna.
Um, for the plans, especially with what I shared, especially on his sandbox, initially we were planning here to do this with the public or with the government consultant providers. But right now, with the discussions with some of the development partners, we are now looking also into probably, and we need to discuss this with the DOH still, is we can also test already the environment with the private if there are those who are willing to be part of the test environment for this integration, for this contracting, and for this payment of a, well, there is no SHF in the public setup, but the idea of providing the global budget through the capitation, providing it in a global budget scheme, we will try to test that also. But again, that would be a part of our policy show and strike shop next week. But we are, before really it was intended for the government, but right now we are trying to consider that to include the private already. So hopefully we can facilitate and we can have more experience on how to deal with the private setup. And technically, I'm not so sure if there will be those who are willing to go into a public mix and private in a primary care setup for this time.
Thank you very much, Dr. Vargas. Dr. Marifea just had to excuse herself, but I will be taking on as moderator for now in the last session. Dr. Mamaril, back to the question that was posed to you, ma'am. How do you think this private sector contract can figure into the theory of change? I guess even into the maturity levels of our UHC implementation sites, ma'am.
Thank you. Well, aside from the UHC Act, which actually emphasize the model, private sector, public, and the mix. Of course, that is the main basis for the UHC theory of change, which we will be recommending to the next administration. So in the current draft, there are 6 pathways, and I think the private sector participation is very clear when it comes to service delivery. So our objective there is patient-centered care. So focusing on the patient, is provided for by providers organized as networks, integrated networks. And one of the strategies there is the private sector participation. So they will be part or they will contribute to the formation of the networks. So we see the vital importance of the private sector because we all know that the resources of the government is very limited. We cannot really do everything. So that's a known fact. We have to accept that. And we really need to learn how to really partner with the private sector. So even in our Philippine Health Facility Development Plan, it already laid out how much resources are needed to really meet the ratio, bed to population ratio na 2.7 nga lang, hindi pa nga the maximum kasi talagang hindi kakayanin ng government lang. And right now, napakalayo pa. So napakalaki ng gap. So if we will continue the way we're doing it right now, na puro public, malayo hindi namin ma-achieve yung target. So yeah, that's the main shift that we really need to do in the coming years, to be more open and paradigm shift nga, as mentioned by Doc. Dami ko nakuha kasi. Yung paradigm shift na parang private sector is for profit lang, na parang you regulate them, So it's really, we should shift our mindset talaga, in the government side. So we have to admit it also. Thank you.
Thank you very much, Director Mamaril. And I think your last comment about making sure that we get to this shift in paradigms, even our perspectives with each other, how private sector sees, or how about public sector sees the private sector, how private sector sees the public sector, or be engaged by the public sector, is something that's also worth looking into, which I think also smoothly brings us to our third session, The first two sessions, we talked about policies, we talked about contracting options and models. But now we look into the softer aspect, the psychographic aspects of engaging the private sector into these HCPNs. Because it is quite possible that we can have very good policies, that we can have attractive and well-designed contracting mechanisms, but if there are no private providers who are willing to buy into these proposed mechanisms, then the viability of these mixed HCPNs or exploring the full potential of engaging the private sector in achieving UHC may not be fully explored. So for this part of our conversation, this is our last session po, but I hope definitely not the least, we have invited Dr. Joni Dichosa to share to us some of the local findings and insights that they've gathered by looking into the readiness and willingness of both public and private stakeholders when we talk about these public-private HCPNs. And we've also invited Ms. Patricia Gomez, Executive Director of IMA, to share with us how, even as early as the start of 2021, how the Integrated Midwives Association of the Philippines has been rallying and mobilizing its members to encourage them at various levels, at various capacities to participate in HCPNs and UHC reforms. So with that, Dr. Joni Dichosa.
Good everybody. Thank you so much, Dr. Jello, for giving us this time. Actually, I'm coming from the field, and as the senior analyst and implementer in the field, we are working with Antique and Guimaras. And thank you for giving us the opportunity to share with you the findings that we have. So initially, I'd like to start off by saying that I am intrigued with the proposals coming from the NWDOH and PhilHealth and all the others who discussed that it would be great to some sort of redirect or direct how the public-private partnership could be in terms of designing them so that we can have more or less a very factual basis for really coming up with a partnership that according to you would be a way forward that could help out fast track everything. So our what metaphor says, backup track, full speed ahead. And talagang yan ang ating pinag-iisipan ngayon, how do we proceed? So in terms of our sharing this afternoon, we would like to share with you the factors influencing the readiness and willingness of the private FP providers to participate in public run HCPNs, as we call it. And these are the insights of Antique and Guimaras. So what we can see here is actually what we are doing since last year until now. And we are very happy that ThinkWell, as appreciated by Antique and Guimaras, has finally assisted these two provinces. One an island province and the other one is an inland province of 3 healthcare provider networks, because in the past they're very hungry of assistance coming from different donor agencies and big NGOs. And finally, they got it. So they're very thankful that ThinkWell has come to their aid. So in this particular presentation or slide, what we're saying here is that after what Dr. Elena has presented in terms of helping the 2 provinces establish the HCPN, they are trying to cup also into a very special entry of the Momentum Private Healthcare Delivery Project, which looks into the possible participation of the private sector in the HCPN. And as you can see, there is on the understanding phase of year 1, which is actually what we are going to present to you. And it tells us of the human approaches, centered approaches, wherein they were interviewed, and we also got so many information from them, so that you can use it actually on how you would like to further move forward and design the public-private partnership in the context of their thoughts, in the context of what is in their hearts, and in the context of what they are working right now, and even in the near past. And the results of which in this sharing that we will give you. This will be further looked into by the project in terms of designing and implementing and develop mechanisms of private sector partners in enabling local private providers to participate in the network. And so this is what we will be doing in the year 2. Now, in this particular slide, we are sharing now with you what we have assessed in terms of readiness and willingness of the public and private sector engaged in the public-private HCPNs. I'd like to start off by saying that kung di ba kayo lahat ay nakaligaw ng babae? Gentlemen? Di ba? Sino yung nililigawan? Yung babae. Ayan. So let us put it in the context of courtship. Wherein yung nililigawan natin, nagliligaw ay ang public sector. So titingnan natin mamaya yan kung paano nagliligaw ang public sector at ano naman yung mga thoughts and reactions ng ating private sector na siyang nililigawan. Let us see how we can move it forward. Kasi sabi natin, move forward, not only to lengthy courtship, but we want a marriage. A marriage that is stable between the public and the private sector. Agree? Ayan. So because of that, we would like to see and move forward na ang titingnan natin ay yung readiness and willingness nila. If you could remember in one of the presentations earlier by one of the speakers, na pagsabi doon na variable willingness and readiness of the private sector and the public sector to join HCPNs and use together as one. So ibig sabihin, the effectivity, the efficiency of the partnership would depend on these drivers. Not only the public, not only the private, but becomes a fusion of two. So that is where we would like to learn from this experience. And, ayan. So sa manliligaw, titingnan natin ano yung findings natin doon sa ating mga nakuhang information in terms of readiness and willingness ng unahin natin yung public sector. Yung public sector natin ay tiningnan yung kanilang readiness for private sector engagement primarily. So yung tatlong aspect which were taken and considered were 1, awareness of family planning needs and service gaps. Are the public sector aware of this? Yun ang tanong natin. So titingnan natin yung kanilang mga sound bites. When we talk of sound bites, we're talking about voices from the ground. At ito yun ang sagot nila sa atin. They said that they are aware of the gaps in family planning, service delivery, and programming, but the problem is they have limited knowledge on private sector engagement. Talagang lahat sila nagsabi niyan, Antique and Guimaras. And in fact, sabi nga ni Dr. Rick Nashangayo happens to be the PHO of Antique, and this was also supported by the PHO of Guimaras. Talagang it was during the time of the pandemic that they finally realized they cannot do it alone. Na talagang they need the private sector, not just as an extension arm, but as a complementary strategic partner, co-stewards and co-owners of the project, of the programs in Guimaras and in Antique. And this is just family planning, but this can be applied in all programs as well. So the second one, in terms of the public sector readiness that was looked into, interviewed among them, KII, FGDs, is that meron bang enabling policy for private sector engagement? Yung sagot naman nila ay, we have not established local guidelines. Wala pa kami naka-execute ng prior contracts engaging the private sectors in public-private partnership, even for family planning and reproductive health. So yun ang sagot nila sa amin. And that is very much documented. And in terms of viability of existing models, meron ba sila for private sector engagement? Tama si Doc Lester, kasi wala pa talaga silang nawala ako. Nawala siya. No? Wala pa talagang mga nagawa na tungkol dito na which is viable. But the thing is that they have worked on the public HCPN referral manuals. Meron sila, no? So ayan, in the process of developing implementing mechanisms for HCPN, but is focused only on the public side. So yan ang ating titingnan din kasi it would help you a lot to have a sense of what's happening on the ground. Yung mga sagot ng maliit na mga probinsya na to, not always assisted by big donors, but who are really working out and striving for public-private partnership. But there is something there that we need to cue in so that it will be integrated into the system of the how, the directions that you might want to focus from the upper level echelon going down to the provinces. And yan ang summary ng kanilang public sector readiness to embrace the private sector into the engagement for the HCPNs. In terms of public sector willingness naman tayo to engage the private sector in HCPNs, tatlo ang tiningnan: attitude, normative, the norms, and the control beliefs that they have. In terms of attitude, ano yung sabi ni public sector? Tingnan natin. Are they willing? Tingnan natin. Ayaw. Wala ka ng baterya? Ayan. There is limited understanding daw nila in the scope of private sector. So anong nangyari? When they organized and set up yung kanilang mga provincial health board, they have, tiningnan namin at tinanong talaga sila, sino ba dito ang mga private sector ninyo na participants or rather member of the provincial health board? Andoon ay CSOs, andoon ay women's group, at iba pa who are not, take note, providers. The fact that these are not service providers is telling us that they are just IEC and advocacy persons who will help out in advocating and communicating, but not as service providers. But that is where the provinces need help. They need help in terms of service provision because even during the times of pandemic, hindi kaya. Walang takbuhan yung mga nanay sa ilalim simply because andoon sila lahat sa COVID na contact tracing o kaya doon sa may vaccination centers and so on. So this is something that we have to think also coming from the ground. In terms of normative beliefs, ang sagot nila ay, kaming mga public sector are hesitant to whether the private sector can align and balance their bottom lines and capability to integrate with the local health system's goals. Kaya pag-isipan natin yan kasi talagang ang tingin ng public, kulang si private to really integrate with them in terms of balancing their bottom lines for the local health system goals. At isa pa, ang tingin nila sa private sector, sa totoo lang ha, kasi I was so glad they were so honest about it, sila ay competitors. Hindi co-owners, hindi co-stewards, hindi strategic partners, but competitors. Kaya ang nangyayari, nagkabanggaan sa ilalim. Matagal na ito kasi sa DOH din ako nanggaling. And I'm always monitoring the different provinces and region 6 at nangyayari ito. Kaya so we were trying to patch up everything and say that we are partners and so on. But then the feeling is different sometimes, especially when competency is at stake. And our NHOs would say, we want you to be competent on this and I want to make sure that you are at equal par with competencies that we have. And that is where we can think about, balancing the act. And the other one is control beliefs. Ang sabi ni public, the idea of the private sector engagement nila is that it is in line with complementation only, extension arm, ibig sabihin, and not as strategic partners. Kaya nga, they are just considered as filler of gaps. Pag kailangan namin kayo, pasok kayo. Pag hindi, dyan lang muna kayo. So ito yung nakita namin. And I'm very glad that they were honest about it talaga. So these are the things in summary na yung manliligaw, ang stand niya ngayon, ang factors affecting their readiness. And it is very important that this will be considered so that somehow there will be buy-in with the public sector to somehow, change a little bit in terms of how they view the private sector. Para pag nanligaw sila, ang sagot agad ay oo. At hindi yung titingnan ko muna. No? Bakit magaling ka bang magmahal? May mga ganon, no? So hold mo na yan. So let's take a look at ano naman yung factors affecting or influencing the readiness of the private sector. Ayan, no? So the same thing was asked of them. KII, K-informant interview, and of course scoping, understanding the landscape as well as the viability of their participation and possible sense of membership for private sector mobilization and together with the public. Readiness pa rin, and then willingness. Pero yung tiningnan natin sa private ay medyo dinagdagan natin. Out there, you can see operational readiness, meaning service capability, resources nila, facilities, and personnel. So ang tiningnan at mga sagot nila dyan ay, ayan. Kaming mga private sector, we accept that there is limited private FP providers. In Antique, there was only one na available at that time na clinic. But because it has 3 HCPNs, healthcare provider networks, North, Central, and South, may mga private hospitals no, andoon. And then meron naman sa Central, may mga clinics din na private. Pero in terms of birthing clinic, isa lang siya sa San Jose. While in Guimaras, there's none at all. Buti na lang sa ngayon, because of Miss Pat's team on the ground, they were able to organize just most recently a stand-alone FP clinic. So, ayan, so it will grow with Miss Pat healing the process among the private midwives. And then, sinabi din nila na we have heard of UHC, but the thing is, we are not fully knowledgeable of what UHC and HCPN is all about. One-time orientation, sabi nila, is not enough. You need to give us progressive and developmental information so that in the process, we can assimilate fully, internalize the whole thing, not just by our hearts, but it has to go also to the head, so that the head can process it and the heart can do something about it and talk about it. And that's what they would like to happen. Kaya yan ang nakita nila na kakulangan sa kanilang sarili. That is affecting their wanting to really join the HCPN on public-private partnership. Another one is kulang sila ng training sa family planning. Kaya Miss Pat's group again, thank you to ThinkWell, has been the sub-awarded para tulungan na makapacitate itong mga private clinics and private hospitals among their midwives and a few nurses so that they can provide the services on the ground in consultation and in coordination, of course, with the RHUs in the different HCPNs. And another thing is that they found themselves very lacking in terms of systems requirements to join the healthcare provider network. So that, again, a design for the next activities that we are doing now is to make them HCPN ready. So yan kasi ang nakikita namin na reason kung bakit mahina yung response nila din. So kaya yan ang status ng operational readiness nila, which is the basis for action in the next run. Another aspect of private sector readiness for participation in the HCPN that was looked into and asked of them is the regulatory readiness, which is on accreditation and the licensing. Alam niyo ba sa dalawang probinsya na to, talagang it was funny because gusto nila, but most are hesitant and some are very resistant to secure. I'm sorry kasi DOH na ako nang galing to DOH, to have to secure the DOH LTO and the PhilHealth accreditation. Kasi sabi daw nila ay very tedious ang proseso at very complex ang requirement. There was one instance na ang Guimaras ay muntik na magkaroon. But you know, after 1 year of the tedious process of running through para lang ma-certify siya through the LTO requirements, she gave up. And so Guimaras has 0 private sector on FP. So, and also, we have noticed that because of the complex requirements, nahihirapan sila even for the renewals. And so, in terms of the readiness, yan ang ating nakikita na dapat tunghayan so that we can help them in terms of what to do so that they can be engaged very well sa panliligaw ng DOH, ng public sector, ng probinsya, para sila ay mag-oo na maging part ng partnership na ito. And in terms of the private sector willingness for participation, tatlo din ang tiningnan, pareho din actually sa public side. Yung attitude, yung norms, at saka yung control, beliefs nila. So in terms of the attitudinal beliefs, sinabi ng mga private sector, all of them actually that we interviewed for the 2 provinces, that they truly acknowledge the potential benefit of being able to join the HCPN, because the people that they serve would be benefiting from it. And of course, ang business nila would also have some sort of ROI, but they don't actually know how to join. In terms of norms, they're unable to make decisions to join without a clear contracting agreement. That is why we're very glad that Dr. Lester said merong gagawin na parang design or sort of format so that it will help the provinces down the line in the contracting agreement. And of course, sabi nila kasi walang clear integration processes. Talagang papel lang siya, UHC, HCPN. But the process, hindi nila mafe-feel down the line, hindi na makikita down the line. So I think it's more on how the downline can clarify with them so that they will understand the process as well. They're also hesitant as to how they can align and comply with the systems arrangement, as mentioned also by the public sector. So ito yung mga qualms nila that they have shared with us. And for the control beliefs, they fear of being over-regulated. Kasi sabi nila parang naaala kami, baka mamaya ay ayaw nila sa amin, baka competitor lang kami, sabi nila, and might not be treated fairly and collegially. Yung bang parang equal na pag-treat, hindi yung parang diyan ka lang kasi mababa ka. Kasi yun ang naging feeling ng mga private bank. And uncertain on how the public system can pay and ensure security of supplies and commodities. Mababayaran ba kami? Baka istorya lang yan, kasi tagal-tagal na yan. Baka next year pa yan or after 2 years pa, kaya mahihirapan lang kami. No? So these are things that we have to look into if we want that there will be public-private partnership to be on the move as we are wanted and designed it to be. And to wrap it up, may mga recommendations silang binigay. Mula ito sa kanila. Sabi nila, both public and private, dapat may solidarity building para meron kaming shared commitment and co-ownership, sabi nila. And second, private FE providers must be onboarded adequately. Tapos i-orient sa UHC, not just once, but progressively, as I have mentioned earlier, so that we will understand it better, we will know what to do. Public sector stakeholders must also be oriented on the private sector para klaro sa kanila na kaya namin, sabi ni private sector. And private sector must be part of the provincial health boards and should have a voice in the design of the HCPN. Because as of now, as was mentioned earlier, even by Dr. Lenz, was that we only have the public HCPN referral manual. So pag andoon si private, they can have a voice in it. And thank you for Ms. Pat and the group for saying yes to this award because they will be helping organizing as well as capacitating the private sector to make sure that it would happen. And implementing models and mechanisms for mixed HCPN, which will be designed concretely, ayan, and tested locally with the private sector as co-owners, co-stewards from the very outset. Hindi yung ibigay lang sa kanila later on. They want to be part of it from the very start. And likewise, the training must be integrated and capacity building must be done together with the public para daw mas ma-appreciate nila at ma-appreciate the public sector na kaya ni private. Okay? And the last, local private providers may organize themselves to ensure easier integration with the public sector. Nahirapan ang public sector to coordinate and to work with individual private sector. Mas maganda pag naka-organize ito so that if they are organized, there will be easier integration and that the public sector can easily appreciate that as well. And so that instead of just courtship along the way, it will be a marriage, not a fixed marriage, but a marriage coming from the heart of the public and the private sector. And that is where we thank ThinkWell because ThinkWell has really done so much on this, and that not only in terms of the findings, but now looking into year 2 so that everything can be done accordingly as planned with the DOH and with the government, which means that with Miss Pat, who is helping now and her team IMAP in organizing, we are ready to move on forward together with them. So thank you very much.
Thank you very much, Dr. John, of course, and thank you very much for staying with us. Although when we thought we are only up to 4 of Jilo, but it's already 4:30.
Yes, po, I'd like to apologize. But perhaps Ms. Pat,
Yeah, 5 minutes, 3 minutes.
5
Okay.
minutes.
Okay.
But of course, not any pressure. I think it's only a testament of the wonderful discussion that we'll be having this afternoon. I hope I would like to ask for the indulgence of our participants. You can stay for a couple of minutes to hear what Ms. Pat has to say. Also, just so we can also discuss very quickly what would be concrete steps moving forward, so how we can help each other.
Okay, so thank you very much, Dr. Jilo, and thank you very much, of course, to ThinkWell for inviting us here in this forum. So what I will be sharing with you this afternoon is a role as an organization with regards to engaging our private sector midwives, and at the same time, our experiences in the ground of what we are doing right now. So thank you very much, Ma'am Johnny. But anyway, much has been said with the UHC Act or Republic Act 11223. We know that. Much has been said, of course, by Dr. Tan and of course, Dr. Merfori regarding this. But I only got, of course, some of the salient points which I think are relevant to the practice of the midwives, because we also has also the, what you call this, the, meron din kaming responsibilidad, of course, di ba, to our members on how are we going to present this UHC law also to the midwives who are most affected. But of course, the government midwives has these people, of course, to ensure that they know about universal healthcare, but for private midwives who are doing that. So we know that this is a law that prescribe, of course, reforms in the healthcare system natin. At na-mention yata kanina ni Dr. Marfori that it should be, the services should be available, accessible, affordable, diba? And of course, protected against, of course, financial risk. So, okay. So we know, again, in Section 4 of that particular law, that it's a part, of course, of orientation to the group, that health facility, which may be a public or a private, then healthcare professionals, kinabi ko naman ito kasi nakasama dyan midwife, di ba? Okay, a healthcare professional be a doctor or medicine, a nurse or a midwife, or a dentist, or other health professionals, no, for that matter, as mentioned, of course, by Ma'am Joni a while ago, and a community-based healthcare organization. Then the pharmacists, of course, the drug outlet, laboratories, and like that. I think that will be a part, they will be a part of our project in both Antique and Guimaras, calling all the health to sector providers, of course, in that particular 2 provinces. Okay. For a while. Okay, so again, we're talking since this 1 p.m. About the healthcare providers network, and we know that already that whether we are public supposed to be and private, but I think on the presentation ni Dr. Tan kanina mukhang we're just having this mix, medyo magkakaroon pa ng on the pipeline pa lang yung ating framework. But I think nauna si Dr. Gilo kasi nga si Dr. Gilo right now is already what you call this, engaging, of course, both our public and private in these 2 provinces. So, but anyway, as mentioned naman, kung mayroong magandang model, much better, diba, Dr. G? So again, offering people-centered comprehensive care in an integrated and coordinated manner, definitely, diba? With the primary healthcare provider acting as navigator and coordinator of the healthcare within the network. This was also mentioned, of course, by Dr. Is. Good afternoon, Dr. Is. Friend na kami. Hindi pa kami friend. Okay, sorry. Hindi pa kami friend. Marami pang pag-uusapan. But anyway, okay. So I would like to introduce, of course, our organization. Maraming pinanggit si Dr. Johnny. But of course, HIMAP is an accredited professional organization by the professional organization, by the PRC. and of course, an accredited family planning training institution by the Department of Health. This is in Region 6, though. But during our NIT meeting, I think Dr. Junice can attest to this, that this was mentioned during the meeting in one of our NIT meeting before. If we are accredited in one region, dapat true to all regions kasi nga, isa lang naman ang requirement na hinihingi. But when I ask, of course, the NCR, sabi hindi, i-apply ulit kayo. Okay, mag-apply ako, di ba? So again, we are also an accredited continuing professional development by the PRC. Kaya sabi ko doon sa mga midwives, pag nag-attend kayo ng training namin, we are very sure na meron ka ng learning and at the same time, CPD units ka pa, di ba? For the renewal of your license kasi accredited training, continuing professional development din kami ng PRC. And of course, we are recipient and implementer, of course, of various PSPH project and programs with, of course, with our development partners. And right now, we have project, of course, with ThinkWell, we have project with Rich Health, USAID. So, mga maliit lang kasi ayoko rin ng malaki do kasi mahirap pala pag malaki. We experienced that already. Okay lang kami sa baba, maliliit lang yun. 6 months, 1 year, di ba? Okay lang yun ka sa amin, di ba? So, but anyway, this is, of course, IMAP as mentioned, of course, by Ma'am Johnny. Of course, what the IMAP or what our organization is doing when it comes to engaging, of course, our private midwives as member of the HCPN. Of course, we encourage, of course, our midwives, no, specifically those in the private practice, to attend fora about the UHC law. Sabi ko kanina, the organization is the one, of course, especially in private sector, to provide them information about the UHC law. And of course, we encourage as well our local leaders to join regular meetings such as regional, provincial implementation coordinating teams based on the RPRH. So, as I mentioned earlier, I'm also a member of the NIT, and of course, we're encouraging our local leaders to become member, of course, of the RICT, in the provincial level, no? PIT. Okay, so the private midwives also participate. No, we do encourage also our private midwives to participate in the maternal death review, given, of course, by the LGU or by our organization. Kasi kung minsan, definitely you have to discuss what happened to this patient, diba, lalo na pag may maternal death in the area. Then we go experiences, of course, our experiences, conducted coordinated meetings to forge partnership with the DOH regional offices, the PHO and the LGU, of course, in training for public and private sector midwives. And in fact, we have this project with the Rich Health, of course, is also in Iloilo and in Negros Occidental. Yeah, that's right. Surprisingly, supposed to be our focus is on the private sector. But we have a lot of public sector already who are not trained. And the issue, another issue is they were providing the services, but they don't have this certificate with them because I think it's only the MSO who train them, then they can do the service. But unfortunately, when we ask them, where are your certificates, wala silang papakita. But before training them to the second level, which is level 2, which is of course PSI and IUD, because we have the trained providers already, no? Of course, this is our project with the same issue before, wherein we trained midwives to be trainer as well. Mentor muna sila, then after mentoring of how many midwives, they can be a trainer. So based in this training needs assessment in the ground, it's not only private midwives pala who needs the training, it's also the public sector. And we're joining in this project in both areas. We're joining, of course, the public sector. So based on the yeah, that's right, yung pinag-usapan namin. So sabi ko, ano ngayon ang feeling ng inyong MHO? Because you know how already to insert IUD, you know how already how to insert PSI. Happy ang kanilang MHO because nobody is the one inserting PSI or subdermal implant. It's because nobody was trained in the area. So yun ang namin. But of course, we are helping, of course, as well our private sector. Then facilitated, of course, our member midwives to be integrated as the FP itinerant team. May mga ibang lugar na working pa yung kanilang interlocal health zone itinerant team. But may iba naman na natulog. So right now in Negros Occidental and Iloilo, parang may ibang area, GIDA ang binigay sa amin ng Rich Health. Wow, GIDA. So yung iba natulog, but yung iba naman ay ginigising naman namin. And they're willing again, di ba, to be working with us as well. No? So maganda naman ang naging resulta. So, but before that, of course, we asked the PHO to draft, or sabi natin, kami kuminsan nagda-draft for them, of course, to just check it, no? For our to integrate, of course, our private midwives into the FP itinerant team, di ba? In conducting, of course, family planning outreach mission in this area. I just would like to share, no, Dr. Dilo dali lang. I just would like to share, I think we have already done how many medical missions in the GIDA area of Negros Occidental. This, I'm very, very proud, Dr. Tan, that in one of the medical mission namin, there were 96 clients. 96 clients. And 91 were, of course, we know I said it. So 91 ang nagpa-insert ng subdermal implant. 91. And the rest, of course, yung the injectables na, pills, etc. And in one, again, of the area in Iloilo, that was in Negros Occidental, yung talagang Makadis, yung kalay-lay na lugar niya. In Iloilo recently, I think one Saturday, kasi ginagawa namin pag Saturday, para at least kasama yung mga public sector. In Iloilo, I think in one of the area na nagkaroon kami ng medical mission, 63 ang client. 63, and we're able to insert 45 PSI. So sabi ko, there's really a gap, di ba, when you say of providing the services, especially in far-flung areas. So, and I'm very proud that the private sector is working together with the public. Kasi ang public nag-arrange, then at the end of the day, this private sector is going to that place para magbigay ng kanilang services. And wala naman silang hinihintay na, na kapalit maybe or financial, wala. No, they just go there to help, of course, this public sector. And again, di ba, we, of course, assist our midwives to be integrated into during this pandemic, no? To be a member, these private midwives, to be a member, of course, of the BHERT as well, no? During this, this pandemic. And of course, we are sustaining, of course, our CSO accreditation with the Department of Health. And of course, a PAPCOM, di ba? Sabi mo, Dr. Julis, kung anong engagement namin ng PAPCOM, di bali na lang, kahit maliit lang, bayad. Okay lang yun, kasi naman wala. Pero si Dr. Isnit lang nagbabayad. Okay. To engage the PPMs, of course, in FPMCH programs together with the public counterparts. Encourage, of course, our private midwives to submit Sir Dr. to submit their monthly report of the MPH report to the RHU. So it's not our accomplishment. Naka-integrate siya doon sa accomplishment ng RHU o kaya ng province. Diba? So that is, diba, an increase in their accomplishment maybe, but some of course of the LGU, like sinabi ni Dr. Johnny, talagang competitor ang tingin nila, especially if that RHU ay may birthing facility. Yun ang problema talaga namin sa ground. So ako naman, siyempre, kailangan ko silang kausapin para naman, di ba, no, we're not competing with each other. We're just augmenting, di ba? Kung ano man yan, complement maybe ang aming ginagawa for what you are doing. Kasi alam naman natin na very, very, tawag nito, masyadong trabaho na yung public, especially during this COVID-19. So yan po ang ginagawa namin, and we're very happy naman, di ba, to work again with the care. Kaya lang, Doc, yung medyo dekahon talaga yung ating mga, yung lalo na yung sa Iloilo, 43 RHU ready sana to have birthing clinics. It's because of the requirement, di ba? Arles. Diyos ko, Doc, 6 lang, 7 ang nakapasa. Diba? Diba meron nga doon naganak sa outside of the birthing RHU kasi nga akala nila operational pa yung pala hindi. Yes, sir, napakahirap. Di ka kung talaga. But anyway, thank you so much. It's the end of my presentation. Diba? Thank you so much, of course, for listening. Thank you, Jack.
Thank you very much, Ma'am Pat. Always a lively discussion with you. But I think if anything, these are examples of non-contractual arrangements that can actually explore and be used as stepping stones for pursuing harder and deeper and broader private sector engagement strategies. And I think that is what IMAP will be doing in the next 3 years or next year at the very least. through the Momentum Private Healthcare Delivery Project with the support of
It's not only
PSPH.
these areas that are engaging with the cause, but I think we're also hearing even for, we are also saying, we develop class of trainer who say everyone. And I hope that you have the accreditation will get the national level. Very good, because it's really submitting the requirements.
Thank you very much, Ms. Pat. So I think the last cluster of discussion was really talking about the demographic, the social cultural considerations, interest management consideration when it comes to engaging these private sector providers in HCPNs. More than the contracts, more than designing the contracts, more than designing the policies. And I think with Ms. Pat, we do realize or acknowledge the role of third-party mediators. It might not just be that it's just the public sector or the private sector. We might need some third-party mediators to facilitate the launching of these public-private HCPNs. Do we have any questions from our participants? From the none from this.
Thank you, Dr. Just actually thank you for all the speakers. My comment very general, and I think I'm trying to put myself in the shoes of our guardians of the health system. Because what I always think whenever there's one disease or specialty focus, to rewind, on joke sa directors ng hospital is, kung ano specialty niya, yun ang magkakaroon ng family. So I can imagine my mindset behind you na may isa pang magsasalita from a different disease program. And I think there's a lot of work inside the now to integrate just the DTC. Fantastic work, very nice. So just putting myself in the shoes now to go back to from our monitoring, what are we going to monitor? Number one, what we learned what if I may is yung process. And I think the traders that already so forgotten. Number two is outcomes rather than inputs nga po. I think that there are reputations always coming in. Minsan they seem to want to buy the inputs, like, oh, we're giving money for the consulta from you distribute bottle. Things like that. And then it just spirals up into the forums and pinipilan na lang yung pinipitaw sa tubo para makilat yung forum. Tapos pinipilo na lang naman yung forums kasi may 60 na health programs. And then number three is, I think, can we make it something discoverable if it's not disruptive? Can it be something that is horizontalizing in a localizable way? What am I talking about? If the rule were something like a functioning local healthcare private network will submit health outcome metrics for each prioritized disease. And if that's the case, it's not important thing so we have outcomes that hindi na-perform, but number of more numerical women of this age group. And then in our study, one example today, different CPG based. That's the fact that for this criteria, we cannot and the CPG says X number of every 6 months, but it doesn't necessarily have to be to the level of audience is telling us that everybody in the country that's talking about the general just in sense. I think the private sector and public sector the kind of
I think it's also dependent on the contract. No? Parang if you look at the 4 typologies there, the PPIs are usually not as flexible as compared to the true PPPs and even the PPIs, which would afford you greater flexibility and not be constrained to whatever is written in the usual contracts. Yes, ma'am.
Yeah. Kasi I come from the Disease Prevention and Control Bureau, and I was once managing the National Safe Motherhood Program. So, ramdam na ramdam ko yung sentimiento ng mga nag-present. We were one of the first programs that really talked about public-private partnership. When we launched the our advocacy on facility-based delivery in 2008, that was a time that nanligaw kami sa mga private sector. Siyempre, yung una namin niligawan, yung mga midwives. So this is an insight, this is not a question. One is, I realized that when you partner with the private sector, you have to make sure that they continue to earn. Yan yung laging tanong sa amin noon. When we were talking in fora and we were discussing this partnership with them, ang tanong lagi is, what is it for us? So kailangan kumikita pa rin sila. Hindi sila nalulugi. Kasi let's face it, the private sector is there. They want to offer a service, but for a fee. Yun yung tawag namin at that time was, this is the model, this is a business model with a heart. Number two is, we have to make the process easy. If we want them to be with us, then we'll have to facilitate the process. Sana hindi yung nahihirapan. Yung mga sinasabing, ang hirap naman kumuha ng LTO o magpa-accredit sa PhilHealth. But of course, we understand that we are also for quality service. And when we talk about accreditation, ang concern natin is the standard of care. Ayaw naman nating madihado yung mga pasyente. So kailangan mag-comply tayo with the regulations, but we will have to make it a little bit easy. If there are 10 steps para makakuha ng license, baka pwede namang mabawasan maging 5. yung mga ganun ba? So yun lang yung naisip ko this afternoon in this session. That number one is we have to make sure that they earn. Number two is we have to facilitate their inclusion into the system. Kasi ngayon, ang dami kong kailangan sagutin na sulat. May mga sulat pa na pinagmumuni-munian ko pa yung isasagot. Kasi ang tingin ko, it's something about regulation. But at the same time, they're also complaining that they're not being reimbursed. Ang sabi sa akin last year for 2 years, and this is now 2022, hanggang ngayon daw. So that's one of the difficulties that the Safe Motherhood Program is facing. Ang sabi ng mga midwives, Ma'am Seni, malapit na kami magsara. At ang sinasabi ko, magsingil na lang. But of course, we don't want that. Sa universal healthcare, ayaw namin ng ganon. Di ba? So, yan yung realization. Thank you.
Thank you for providing those presentations. Just to provide also some insights on possibly responses. With regards to training and orientation po on UHC law and the UH Academy po, which is the learn.uh.gov.ph is open po for everyone. There are courses there for UHC and many others that are open for public and the private sector to avail of. Just have to register in that online platform, and you can the course are already uploaded. Out of 12 modules yung naka-upload in open access. And then with regards to the license to operate, at sinabi naman na po ni Ma'am Seni na these are the standards, but yun po din yung sinasabi namin na sa UHC law, may provision po kasi doon that there should be preferential licensing for health facilities in GDAS. Now, ang ginawa po ng licensing bureau is they have issued out a policy that would hopefully somehow simplify the licensing process for those facilities in GDAS. Ang initial discussion po namin, particularly Yusek Villaverde, is that sana medyo may konting leeway for those facilities in GDAS. Unfortunately, hindi ganun yung thinking po ng aming Health Facility Regulation Bureau. Sabi nila, standards are standards and we will only facilitate or fast track the licensing. So, yun po, that's where we are now. So, with regards to the licensing. And particularly, I appreciated po yung efforts ng binanggit po ni Ma'am Pat on IMAP when they mentioned that they are, as a private sector, they are providing public health services, and of course, the commodities are coming from the government, and this one form of public-private partnership And they also encourage the private midwives to submit reports to the RHUs. And this, as also I mentioned, as part of the non-contractual arrangements or agreements between the public and the private. So I also nagulat lang din po ako nung sinabi ni Dr. Johnny na yung pong membership ng private sector sa Provincial Health Board are mostly are CSOs and not really involved in health service provision. Kasi nakalagay po yata sa local government code is that it should be CSO or private sector involved in health services or something like that. I'm not really sure, but yun po ya dapat talaga yung membership sa health board. Thank you po.
Thank you very much, Dr. Tan. I think thank you very much for opening that or sharing that resource that I think even the group of Ms. Pat can use to further mainstream their efforts of educating their members about the HCPN. Yes, ma'am, Pat.
Yeah, siguro to, sa pagtingin din natin, because you are parang the list of the requirements, di ba, for us to open a birthing clinics, napakahaba, di ba? But I think the most important thing there is yung referral tertiary hospital. Kasi kami pang naghahanap eh. And we know who our patients are. Diba? Hindi po pwede kami mag-refer sa private because of the paying capacity ng pasyente namin. Diba? So kami pa ba maghahanap or dapat magiging automatic na yon? Like for example, sabi ni Dr. kanina, accessibility, diba? In the distance from our clinic to a tertiary hospital. The problem is, Dr. Gino, may utang pa tayo sa Pasig because napakabagal, sir. Kasi nga, di ba, dapat ang aming MOA lang is to the tertiary hospital owned by the government. Kasi nga, sabi yung carrying capacity ng pasyente natin. But the problem is, kami pa maghahanap. And of course, pag kamuha mo ang public hospital, dapat, hindi ka na, sir, di ba, maghanap ng OB and private na IPEDSA. And we're still paying, of course, our OB in PEDSA as partner. The same with the ambulance. Di ba ang ambulance namin, even without using it, nagbabayad kami monthly. So, yes, di ba? So, parang nagiging money na lang in everything, di ba? Tapos ngayon, hindi pa kami binabayad ni Doc Is, di ba? No, to tell you frankly kasi, di ba, Doc Is, alam mo yon na nagpakabayan interview pa ako because of that. Because sa totoo lang, Doc, gusto na namin mag-detach sa PhilHealth. And this is really, Doc, totoo ito, ang sabi ng private. Kasi nga, 2017, 2018 ba naman nakutang? And a private facility, napakaliit, may utang time to million. Eh, di ba? So, mahirap i-sustain. At here in NCR, marami na Dok lang nag-detach sa PhilHealth. Anyway, they can make singil sa pasyente. Bago pumasok ang pasyente, kausapin nila, hindi na ako PhilHealth, but willing to pay. Ito, di ba? Thank you.
Surfacing some issues that most of us, if not all of us, already know. But I think it's also very important for us to be mindful about how the HCPN can actually be leveraged and how the whole HCPN design can be leveraged to address these issues, these very, very important issues that we've surfaced. Pat, and I think just also bring it back to our discussion. These are actually the kinds of arrangements that you can embed within contracts to make them evident so that it's clear for both parties engaged. This is your responsibility for payment and repayments, expectations of each other. So, any other questions? I guess we are now at this point where, yes, ma'am.
I just have to make this clarification kasi parang I get a message that we're being prodded to be entrepreneurial, and we are not. No, not all, I would call not non-government, no? Non-government. Kasi parang, some of us really probably have to venture into private kasi we need to survive. But some of us, because of our mission talaga, and the fact that we're lucky sometimes to get development partners to subsidize our personal cost, talagang hindi kami nag-charge. And I think there should be a room in the financial scheme of things na meron talagang area na for a non-government agency that functions very much like government. In the sense na talagang free ang services, no? Wala talaga, etc. And that's where we need PhilHealth actually. That's where we need PhilHealth support. Kasi hindi pwedeng mga, di ba, when you're supporting the poor, you cannot patong-patong other, otherwise and I'm very worried nga dito sa ating objectives for health na alam natin na kataas ng ating out-of-pocket, 54%, and yet the target of the Department of Health is only a reduction of out-of-pocket from 54 to 50? It's, I think we need to, objective of health, it doesn't jive. So, maka-particular lang ako talaga no na, I think, social insurance, kaya we really need to subsidize the poor so that they can accelerate their outcomes. No? And I'm worried when we're all talking about business and we're lumping everything together. Hindi lahat business din health.
So siguro from an academic standpoint, not both, no? I think what I'm trying to do is I think what's happening is we're playing a catch-up game, not for business, but for system. Because in the super soon office, we have NGO provision when there's a failure of the market, which the market demand is providing when there's a failure of public services for government. And by the way, that's not a perfect statement, but that's just one view that we all try to use to explain why we have this ecosystem. So in other words, if this catch-up, which I traced all the way back, in a study from the 70s and so on for underinvestment, and most of the growth being private sector, if you look at that count, etc. This catch-up from the population we had then, the population we have now, from the stagnant public health statistics at full time. If we strengthen this catch-up, parang the UHC and its mindset is like that, then we will fill up those gaps which you are filling, which everybody is good for that they're filling. And so this graph, I guess, obviously the implication is, yes, there are choices to be made in the sense that it might look like a competition between the horizontal and the vertical one. But at the end of the day, the diagonalization is where it's going to go. From Guimaras and Antique, a couple of weeks ago, was referred to me by Doc Rick, one author, a different NGO, international also, well-funded, respected actually, and good at their job in several provinces. But my message to them when we were to get a great one to discuss, and I said, what's easier for you? Hi, we are so-and-so NGO, do it, we'll help, fund us, we're good. Or, hi, we are so-and-so, we're good at our job, and when we do it for this disease, for this body organ system, others improve also. And that's where the metrics comes in. Like when we introduce that program, again, just the easy example is, do we count condoms? Or do we count, patient encounters or health outcomes or whatever it is, but improve access, something horizontal within your sphere. So I'm just trying to diagonalize it and give historical perspective for why, to go back to your earlier comment, we're all trying to not let people fall through the gaps. The only difference is whether we select some people or all of them.
Mindset. And but also at the same time, I think there are also clear opportunities, Dr. Melgar, of explore. I think number one is also widening our definition of private sector, because private sector is not always for-profit private sector. So I think that perspective has to be clarified, to implementers, to policymakers. And then, ma'am, definitely, we acknowledge the huge contribution of civil society organizations, not for profit civil society organizations, when it comes to filling these service delivery gaps. But I think the opportunity here is how do we formalize and integrate effectively what you are currently now doing strictly. I mean, you may say, ma'am, that you are doing something that's already very much similar to what public facilities are doing. Diba? But I think the opportunity provided by HCPNs is how do we make sure that you're integrated well and it's not two separate entities doing the same thing. Maybe there's an opportunity for complementation, even sharing of resources, even joint program learning. So I think maybe that's another contract code that we can explore, no? Contracts
No,
with
actually, I'm very gladdened by the fact that even Dr. Tan, Dr. Ish are saying, hindi pa tapos talaga yan. Kasi parang marami nga tayong, I think, ang dami parang wala talagang puno na templates, di ba? And we're still, ano ba yung primary to tertiary ba yan? O meron bang mga horizontal? I think I think we are gladdened by that, na parang our policymakers are really thinking of what an appropriate scheme could work for all the different kinds of providers. So we hope to be in conversation with you. Kasi nga, we also want to have a place for NGOs that are really non-profit, di ba? And are also doing good work, I think, where we are.
Dr. Lechika, sir.
So I understand that the UH law naman contemplates private sector as in terms of the service provision. So if CSOs or even like private corporations can provide the service, that's part within the idea of healthcare provider network. So pwedeng primary care ang pinoprovide. So I think what's going to be critical is how we yung details, I think, with the arrangement. And we go back to contracting. Earlier, I had this thought that in terms of contracting, the one that needs capacity building more is the public sector, because for private sector, usually they're like designed to really maximize profit, and they're adept at these types of engagement. But now I realize but because that throughout this discussion, it was raised that CSOs also need to be engaged also. So that's, I think there should also be some room for building capacity of CSOs in entering these types of agreement. Because as we parang realization din, we've been engaging like public-private partnership. It's not a new thing. No? So parang if you include user fees, as Dodo mentioned, it's pretty straightforward. So, because pag magbabayad naman yung pasyente, madali lang, pa-partner tayo basta magbabayad. But the challenge actually is to maximize we have this parang fiscal constraints, because PhilHealth lang naman yung magdadrive ng financing of engagement under the framework of UHC. So you have to be creative, and I think it all boils down to the details of the engagement. Kasi I've been seeing some of those parang minute engagement in some of our sites. For example, in TB, may private hospital, usually they get the TB cases. They refer it to the DOTS. Tapos may referral fee, LGU gives a referral fee to the private hospital or to the private doctor using the capitation or the reimbursement from TB. So mga ganong type of engagement. But of course, it's a small thing. Mutually beneficial, sustainable. But yung challenge actually is pag we include na the entire breadth of service provision, that would be very, very challenging in the way we enter into contract. So I think that's a key realization in terms of public-private partnership engagement in the context of